Okay. Ashley, are you there?
I'm here.
All right. Basola, are you there? Or folks from cable, you guys there?
Good afternoon, council member. We're ready to go when you are.
Okay. All righty. All right, let's get started. Good afternoon. I'd like to call this hearing to order. I am at-large council member Christina Henderson, chair of the Committee on Health. Today is Tuesday, February 28th, 2023. The time is 2:00. We are holding a virtual meeting via the Zoom internet platform. This meeting is also broadcast live on cable channel 12 and on my YouTube page at CMC Henderson. Today, we are going to be talking to some of our boards that are under the health cluster. The Health Regulation and Licensing Administration, or HRLA, is a division of DC Health that seeks to protect the health of district residents and those that do business here by fostering excellence and health professional practice and building quality and safety into the health systems and facilities through effective regulatory framework. HRLA boards administers the licensures of almost 70,000 health professionals in the district, supporting 19 health professional boards, including the 5 boards that we will cover today. The boards advise DC Health in matters pertaining to the development of rules and regulations for health professions and provide additional services, including licensure verification and licensure examinations. Today, we will hear testimony from public witnesses and the chairs of 5 licensing boards, including the Board of Medicine, the Board of Nursing, the Board of Pharmacy, the Board of Psychology, and the Board of Social Work. Members of all 5 boards are appointed by the mayor with the advice and consent of the council. The boards evaluate applicants' qualifications and administer examinations. They recommend standards and procedures and issue licenses. Boards also receive and review complaints, request investigations, conduct hearings, issue subpoenas, examine witnesses, and administer oaths. The Board of Medicine, which oversees regulation of physicians, trauma techs, physician assistants, and the range goes further. Let's talk about the Board of Nursing, whose mission is to safeguard the public health and well-being by assuring safe quality care in the district. They also do licensure, registration, continuing education of nursing professionals here in the district. The Board of Pharmacy regulates the practice of pharmacy and practice of pharmaceutical detailing in the district. They evaluate applications, they recommend standards and procedures, they issue licenses, and also review complaints as well. Similar for the Board of Psychology and the Board of Social Work. The committee sent written pre-hearing questions to DC Health on these 5 boards, and we will reference those materials today. If anyone watching would like to see the materials, they can be found online on the council website, dccouncil.gov. I don't see any of my colleagues here, so I will keep moving. Before we get started, I want to review the testimony guidelines for the public witnesses. Witnesses representing an organization will have 5 minutes to speak, and the witnesses testifying on their own behalf will have 3 minutes to speak. We will have a clock that you can see right here on the screen that will begin counting down when you start speaking. I will give you a nudge when your time has expired, as we do have some time constraints today. For anyone who is not able to speak, but still wants to be heard, we will accept public testimony until March 14th at 5 p.m. You can submit those written statements to my staff, and I'll provide those instructions at the end of this hearing. Okay, so now we will call up our first panel of witnesses. And just for anyone sort of thinking about forward, what will happen, we are going to hear from each of the boards separately. And so we'll go with Board of Medicine first, then we'll do nursing, pharmacy, psychology, and then we'll wrap up with social work. Okay, we're going to do panels of 5. So William Long, public witness. Susan Bathgate, president of the Medical Society of DC. Claudia Schlossberg, public witness. Lucia Rosa, a student at Gonzaga High School. And Justin Palmer, VP at the Hospital Association. In order to come in to the room, you have to affirmatively accept our invitation to be a panelist. And so we'll give it a minute while folks come over. Okay, I don't see William Long, but I do see Suzanne. So Suzanne, why don't you go ahead with your testimony? And Suzanne, if you're speaking, you are on mute. Suzanne? Okay. Claudia, why don't we start with you?
Okay, I'm happy to do so.
Thanks.
Great. Chairperson Henderson, members of the Committee on Health, thank you for the opportunity to testify this afternoon. I am Claudia Schlossberg. I am the interim convener of the DC Coalition on Long-Term Care that brings together consumers, advocates, providers, provider associations, and organized labor to improve access to high-quality care for district seniors and people with disabilities. You've heard me in previous hearings and in other forums talking about the very serious healthcare workforce shortage we face, particularly among direct care workers, that's affecting access to care as well as driving up healthcare costs. We know that to recruit and retain more people to these jobs, they have to be more attractive. And the primary way to do that is addressing the wage gap, the wage penalty that these workers face. And you've heard me testify that we need to raise the wage rate to $24 an hour. Today, however, I'm going to focus on the actions that the Department of Health and the Board of Nursing can take to help address this crisis. First, we need to amend the Health Occupations Regulations Act to lower the age requirement for direct care workers from 18 to 16. This is a win-win strategy that benefits students with paid employment in entry-level jobs at an early age that can and often do lead to lifelong, well-compensated careers in the health sector. It also benefits employers by creating a pipeline of workers who can work part-time and take evening and weekend shifts that are often difficult to fill. And many of these jobs are right in their own neighborhood. Second, we need to eliminate a fragmented and siloed approach to training and certification of direct care workers. Currently, the Board of Nursing oversees separate rules, separate approved training schools, and separate exams for home health aides and certified nursing assistants. And CNAs cannot work in a home environment unless they take additional training and take an additional exam at additional expense. Yet the approved curriculum and competency standards for both of these positions are virtually identical. We need to consolidate the curriculums for these two courses and train all direct care workers to the highest level of their competency so that upon certification, they can work in any environment, just like we do with nurses. This gives the worker choice and flexibility, including the opportunity to pick up shifts or extra care or work as desired. It also significantly increases the capacity of our approved training schools to train individuals to work in home care, which is where we have the greatest unmet need and the least investment. Third, the council, and I would say pending this, we need to eliminate the bridge course and allow the waiver that we had during the pandemic, which allowed CNAs to work in home care during the pandemic, but is not allowed now. The council must also enact legislation to require and authorize the Board of Nursing to enter into the Nurse Licensure Compact. The nursing shortage does not just affect bedside care. It's also delaying access to Medicaid benefits because the current assessment contractor, Liberty Health, cannot find enough nurses to conduct assessments timely. Just yesterday, I heard, and this morning as well, assessments being requested today are being scheduled in mid-May. The inability of the training schools to expand capacity and new courses. Again, I hear from training providers that I am in touch with that they cannot find DC licensed nurses to teach new courses or expand their course offerings. It also delays certification of newly trained aides. Credentia, the Board of Nursing's testing contractor, has had to cancel and postpone skills testing dates numerous times because they do not have enough DC licensed nurses to evaluate the students. The Nurse Licensure Compact allows nurses to have a multi-state license and to practice in any state that's part of the compact. And there are 39 states already part of the compact, including every jurisdiction that surround us: Maryland, Delaware, Virginia, West Virginia. And there are 8 states that are in the process of enacting legislation to join the compact. There's no adequate reason for not participating in the Nurse Licensure Compact. Fourth, the Board of Nursing needs to move quickly to approve pending applications and promote medication aid training. Employers are anxious for their incumbent aides to receive this training and obtain this certification because it helps reduce the workload of licensed nurses while advancing the skills and increasing the pay of their direct care staff, which is a known proven strategy for helping recruit and retain staff. In other words, this is a real step in a career ladder that benefits the worker and the employers. We have been waiting since 2019 when the BON finalized the medication aid regulations. Why is it taking so long to stand up programs to get these aids certified as medication aids? I have listed other recommendations in my testimony, which I don't have time to go over. I just want to say in closing, we need to fill thousands of direct care jobs to meet current demand and future needs. To have any hope of meeting this demand, we need focused, coordinated action across multiple agencies to address systemic and operational deficiencies. We need leadership to drive needed reform, and we need you and members of the council to hold agencies accountable. Thank you for the opportunity. I'm happy to answer any questions.
Thank you, Claudia. I don't see Lucia, so we will go to Justin, and then Suzanne, we will come back to you.
Good afternoon, Chair Henderson and members of the Committee on Health. My name is Justin Palmer. I'm the Vice President for Public Policy and External Affairs for the District of Columbia Hospital Association. I appreciate the opportunity to present testimony at the Performance Oversight hearing for the Health Professional Licensing Boards. As you're aware, the district's hospitals employ over 30,000 individuals, many of whom are licensed healthcare providers. Whether they are nurses, doctors, respiratory therapists, or certified nursing assistants, they all have to traverse the licensure, registration, or certification process. We are grateful for the work of Dr. Lewis and Interim Senior Deputy Director Erin Gibson for their assistance over the last 3 years as we've navigated a healthcare labor market that has been flipped on its head. This has increased the number of licenses being processed, especially for the Board of Nursing. The hospitals also recognize the work being done to bring additional licensing specialists on board as authorized in the FY23 budget. These additional hands will help to speed up the licensure process. While so much has been done to streamline the licensure process, there is still much work to do. Please understand our recommendations today are not meant to minimize the work of the dedicated employees of the Office of Health Professional Licensing. As a former consumer member of the Board of Chiropractic, I have seen firsthand the dedication of the boards and the staff members. It is clear that the IT systems and the complexity of the licensure process is creating pain points within the licensure process that are frustrating applicants and employers. We need to move to a system that is designed not to accept applications until they are complete, which is not the case now. Right now, the licensee sees a dashboard with all green indicating the application is complete when their items may be missing. This leads to frustrating calls frustrating calls and emails to the boards by applicants seeking to know why their license has not been approved and what documentation is missing. Additionally, the boards need to be clear with applicants about where to find the link to schedule their fingerprinting. Applicants are missing the links because they're being marked as spam. And this is also happening with follow-up emails that are sent through the Salesforce licensure system. We also encourage the boards to examine their processes and remove unneeded steps that create barriers to licensure. DCHA encourages a closer look at the testing for CNAs. Currently, there's a backlog of applicants waiting to take the CNA test because of cancellation dates. We are grateful for the collaboration with Dr. Walsh and the work being done to resolve the differences between testing sites and Credentia. But as Ms. Schlossberg noted, part of it has to do with the ability to recruit examiners. We also recommend that during the budget process, additional funding being allocated not only to IT updates, but customer service representatives to answer the phones and assist applicants. We received many complaints of individuals not being able to reach a licensing specialist via phone, which often leads to trips to 899 North Capitol Street and frustration by the applicants. Again, I do want to recognize the work of the executive directors and the licensing specialists. Their work has assisted DCHA in resolving over 480 delayed applications over the last few years. Finally, while we know that there are disagreements about the need to join the nursing compact, our members believe that it is essential for a streamlined licensure process for nurses. Given the increase in nursing application, it only makes sense to join the other 39 jurisdictions that have joined the compact. There are about 9 states that have pending legislation to join the compact, leaving only American Samoa, California, Connecticut, Michigan, Northern Mariana Islands, and the District of Columbia as the jurisdictions not moving forward with towards the compact. Thank you for allowing me to testify, and I'm happy to answer any questions.
Thank you. Suzanne?
Hello. Thank you for your patience with my IT. I really appreciate it. I come to you today representing the Medical Society of the District of Columbia as the current president. The Medical Society of the District of Columbia, MSDC, is the largest medical organization representing metropolitan Washington physicians in the district. We advocate on behalf of 11,000 plus licensed physicians in the district and seek to make the district the best place to practice medicine. I want to thank you for holding this oversight of various health licensing boards. I want to begin by saying that the Board of Medicine, which we work closest with, is responsive to the Medical Society and our members. We have partnered on various issues throughout the year, most recently the 2022 medical license renewal, and valued our working relationship. We especially appreciate the respect given by the board to our Physician Health Committee, which advocates and supports physicians dealing with addiction. We know that post-2020, physician addiction and suicides are on the rise, and the committee is available to provide additional support to the board. However, an increase in referrals and expert assistance cannot be accommodated without a corresponding grant or funding source within the department. MSDC is specifically concerned about 4 issues that I'd like to present. The first is we'd like to see a change in harmful language around wellness and addiction. The Mayor's Healthcare Workforce Task Force included a recommendation in this draft to limit fitness for duty questions during application and renewal cycles such that they only apply to current impairment to practice safely. The Dr. Lorna Breen Heroes Foundation has identified the district as one of the states whose licensure language can harm physician wellness by forcing unnecessary disclosure of past impairment and wellness treatment. We urge the Board of Medicine, if necessary, the council to remove this language. Next, we recommend implementation of regional license reciprocity as soon as possible. The Board of Medicine has shared regional reciprocity should be online in the summer of 2023. The council must keep the boards to this timeline and ensure that the DMV license reciprocity process is fully operational, including IT infrastructure. MSDC has long championed the need for area physicians licensed in one state to easily apply for a license in the other without totally redoing their application. We also firmly believe that a regional license should be less expensive than going through the regular license. Third, we'd like to see staff up customer service support during license renewal times. MSDC stands up its own license renewal center and takes calls and emails from members, helping them through the process. We even arrange office hours for members to come in and sit down to complete their applications with us. We did this not only as a service, but because it is hard to get in and get answers to questions about licensing and relicensing. The DC government should look at how it funds customer support personnel for the boards. And lastly, we would like to work with the council to remove the LGBTQ cultural competency CME requirements. MSDC and its members believe that content-specific mandated CME is wrong, as government through the licensing process should not dictate what learning is essential to the practice of medicine. The mandatory 2 hours of LGBTQ cultural competency remains a requirement due to council legislation. We urge the council to repeal the requirement, not because we oppose LGBTQ cultural competency education, but because it is another mandate for all physicians, regardless of practice type. Please reach out to the MSDC office if our membership can be of assistance on any issue. We look forward to working with you and the committee to make the district the best place to practice medicine. Thank you for the opportunity to speak.
Thank you all for being here today and multiple days. I've seen some of you at some of our other hearings as well. And I've also met with all of you and we've discussed some of these licensing issues. So I also had long meeting with HRLA to talk about the health licensing process and wanting to better understand what goes into it for the various boards. How do they decide how many staff are assigned to specific boards to help in terms of the processing and those kinds of things, and even asking questions in terms of compacts, which I think, Claudia, you brought up, and then Suzanne, you also talked a little bit about from the reciprocity standpoint. So my understanding is that the psychology compact is already live at this point. So with the Board of Psychology, the Board of Medicine compact with Maryland is about to go live in Q2. And then they're working on physical therapy. One of the things that has come up, though, is an understanding that when we join a compact, we have to essentially accept whatever someone else in another jurisdiction is doing. So, for example, one of the issues that has been a sticking point with Virginia is that Virginia doesn't require a background check for folks who are going through their, say, Board of Medicine licensing, but we do. Do you all feel like that shouldn't necessarily be a sticking point for us to sort of move forward in this regard? I'm trying to understand to what extent I think it's important, but I'm curious what you all are feeling from, the folks on the ground.
So if I could respond to that, we have a shortage of nurses. There, I believe something like 30,000 nurses that are currently licensed to practice in DC, but we don't know how many of them actually live in DC. I suspect it's not very many of them. And so we're pulling from a very small pool to try and, to try to fill all of these positions. I think being part of this compact is essential to addressing the nursing shortage. We are a healthcare hub. People are coming here for jobs, and the licensing process, as you have heard, and I have heard from many of my clients, for example, Mary Center waited 6 months to try to get one of their NFP nurses licensed in the district. That delayed their program, being able to serve women in that program for 6 months. That's just not acceptable. What I have heard, and I'm not an expert on this, but I'm working with somebody who knows a lot more about it than I do, that some states have added additional safeguards to their compact legislation. So, for example, I just was sent some legislation from Ohio. I haven't had a chance to look at it, but I think there are ways to deal with those specific objections. And if there are specific objections, let's raise them and address them in a way that makes sense, because this is going on far too long and we are in such dire need of nurses. It is, again, not just affecting bedside care. It is affecting access to care for Medicaid beneficiaries. It's affecting being able to train more direct care workers. We need to get this done.
I haven't heard the concern about the background checks before, so that's a new concern. But I think from at least from a hospital standpoint, the hospitals run background checks on at least all of the non-licensed or non-licensed health professionals as they're required to. So I think that there are ways that we can add that safeguard if that needs to be addressed. And I don't think there would be concern because it's a practice already for other employees in health facilities.
And that's true. Other healthcare facilities have to run those background checks when they employ people. So that's correct.
Okay. All right. I'm going to be mindful of my time. And because I've had conversations with all of you, I'll follow up in asking not just the Board of Nursing in terms of the compact piece, but DC Health is in front of the committee on Thursday. So this will certainly be part of that conversation as they are part of that work. So thank you guys for being here. We've been joined by Councilmember Parker, Councilmember who is a member of this committee, and the Councilmember for Ward 5. Councilmember Parker, you have a round of questions with these witnesses.
Thank you, Chair Henderson. And I am jumping in between hearings, which is everybody's reality nowadays. I unfortunately missed the majority of the testimony, so I will be brief, but Ms. Bathgate, I did catch the tail end of yours, and I just want to learn more. If you could just speak more to the LGBTQ requirement that is in place that you're advocating for removing, and what relief you believe that would provide, as well as why you think that's necessary.
So actually, we advocate for not having specific CME as part of the licensing process. We would like to have the physicians choose what is most beneficial to their practice. If you're a radiologist, you probably don't have a whole lot of LGBTQ need for training. And so we'd like to let that, the cost of that, the time of that, be put towards something that is actually beneficial to practice. And that's, it's not just LGBTQ, it's advocating against any specific CME content, but that happens to be the one that's in place right now.
Got it. And what barrier would you argue that it's posing right now for physicians that are seeking their license?
It's additional expense, it's additional time. So the cost of LGBTQ of 2 hours is probably something like $75. And it's 2 hours of time commitment and that those resources could be spent on something that's directly applicable to their practice. And they could choose LGBTQ. That could be on the menu of choices, but to mandate that is something we advocate against.
And have you given consideration to why it may have been mandated before?
Yes. Usually we have had over time different special interests request mandated CME. And so I like I said, I don't think that I'm absolutely not against LGBTQ cultural competency. In fact, at GW, we just opened up our Center for Sexual Health and Gender Affirmation. We are very big in this area, promoting excellent healthcare for people of this group. But to mandate the CME is what we oppose.
Got it. Thank you for that. Those are again, I missed the majority, but I would just say that while I'm not fully versed in this requirement, I imagine it was put in place to just build cultural competency across the board. And we know not just with LGBTQ neighbors, but Black women and a host of others have for years told us around how there are barriers to receiving quality care. And it's often because those on the other end of providing that care don't have those cultural competencies. And so while I do have concerns with barriers, I will be honest to say I'm not fully persuaded that 2 hours or $75 seems like that much of a barrier. I do appreciate your testimony and will, because of it, do a little bit more homework into the matter. And we'll follow up as necessary. With that, Chair Henderson, I will turn it back over to you and look forward to further commentary.
Thank you, Councilmember Parker. Okay, thank you to this panel of witnesses. You'll be put back as an attendee, and we will call up the next panel of 5. Clayton Brightwell, Mark Lavoda, Amber Reike, Sue Breitkoff, and Will Doyle. And just as a reminder for those who are joining us, in order to join as a panelist, you do have to affirmatively accept our invitation to be elevated to a panelist. Okay, I don't see Clayton. But I do see Mark, so we want to keep going. So Mark, why don't you go ahead with your testimony?
Great, thanks. Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association advances high-quality whole person care for district residents with mental illness or substance use disorders. Our 31 member organizations provide care to over 30,000 district residents annually. In the midst of significant healthcare workforce shortages, we're grateful for today's opportunity to testify regarding the performance of district health professional licensing boards. Member organizations belonging to the District of Columbia Behavioral Health Association provide a substantial service to the profession of social work in the district by hosting social work student interns at the bachelor's and master's levels and serving as major employers for licensed social workers at every career stage. Before turning specifically to the Board of Social Work, I encourage the Committee on Health to consider holding a roundtable to review the Mayor's Healthcare Workforce Task Force report and recommendations once the report is released. We have several recommendations for the Board of Social Work. First, the Board of Social Work should discontinue use of national exams for the bachelor and graduate levels of licensure. The Association of Social Work Boards reports initial pass rates of 93% for white test takers and 52% for black test takers, and eventual pass rates of 97% for white test takers and only 75% for black test takers. The Board of Social Work requires passing the national exams despite these known disparities. Multiple other conditions of licensure ensure that applicants would be able to practice safely without relying on these exams. Relying on exams with known racial disparities deters Black social work degree holders from completing licensure and deprives our communities of social workers who look like and come from the communities that they serve. Racial economic inequities likely exacerbate the consequences of revoking permission to work for Black applicants who fail the exam, but might otherwise have sought to continue work in the field. Second, if use of the national exam is not discontinued, the Board of Social Work needs to issue letters of supervised practice promptly to eligible applicants, and it needs to expand the use of those letters. The board should offer letters for 120 days, allow applicants to continue to work under a letter even if the exam is failed, so long as they schedule to take the exam again, and offer renewals for additional 120-day periods for applicants who show good faith intent to continue to take the exam and work to achieve a passing score. Third, the Board of Social Work should recognize LICSWs as qualified supervisors for individuals seeking to become LISWs. Since the Board of Social Work recognizes that the services conducted by LISWs are a subset of the services conducted by LICSWs, the board should allow LICSWs to fulfill the supervision requirements needed by those seeking to be licensed as LISWs. Fourth, the Board of Social Work should make recommendations to change the DC code to expand recognition of qualified supervisors other than licensed independent clinical social workers for individuals with bachelor and graduate levels of licensure. Combined with updates to the DC code, the Board of Social Work should adopt policies to allow general supervision, as well as up to half of the hours under direct clinical supervision to be provided by a range of independently licensed professionals not restricted to LICSWs, minimally including psychiatrists, psychologists, psychiatric advanced practice registered nurses, and licensed professional counselors. Fifth, the Board of Social Work should make recommendations to change the DC code to update levels of licensure and scopes of practice to correspond more closely with the Association of Social Work Boards Model Social Work Practice Act. There's value in offering a path to independent licensure at each bachelor and graduate level, as well as a higher level independent clinical license and defined scopes of practice for each level of licensure. The Board of Social Work recommendations for updating scopes of practice for each level of licensure should include a clear goal to end long-standing conflict between the Board of Social Work and individuals in unlicensed health occupations with overlapping but not exclusive services compared with the practice of social work. Scopes of practice for each level of licensure should focus on the distinctive elements of social work practice to avoid interpretations that continue to lead to unconstructed disciplinary actions against people categorically ineligible for licensure by the Board of Social Work or any other DC health licensing board. Six, the Board of Social Work should recommend changes to the structure of the board. The composition should be restructured to align with updated levels of licensure, relying on the independently licensed individuals at each level of licensure. Before I conclude today, I want to express concern for the safety of the community being undermined when there's not an adequate workforce. Unnecessary barriers to licensure for individuals who can be trusted to deliver care with adequate safety, reduce access to care, and threaten the quality of care that an understaffed healthcare workforce can deliver. The Council should enact a statutory requirement that each health licensing board is expected to review the impact of its decisions, both on individual safety and also on community safety, based on workforce availability. Thank you for the opportunity to testify today. I look forward to any questions you might have.
Thank you, Mark. Amber?
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Amber Reiki. I am the Path Forward Project Lead at Children's Law Center. Our more than 100 staff work with DC children and families, community partners, and pro bono attorneys toward a future where every child can grow up with a strong foundation of family, health, and education, and live in a world free from poverty, trauma, racism, and other forms of oppression. I appreciate the opportunity to testify today about the Board of Social Work's important role in DC's behavioral healthcare landscape and in the current workforce crunch. Today's testimony will outline 3 recommendations for the board to improve DC residents' access to timely, high-quality, consistent, and culturally responsive behavioral healthcare. Align activities of the board with the goal to maintain an adequate network of behavioral health professionals as a matter of patient safety. 2, increase capacity for licensing administration. And 3, create and maintain a database to inform behavioral health workforce planning. As you well know, and I've been here before you a few times this month to say, we are in a national and local mental health crisis for children and families. Recent District of Columbia budgets have represented a significant paradigm shift by recognizing the centrality of behavioral health to community well-being. At the same time, the shift has revealed sizable workforce challenges. Programs are competing to employ social workers amid a national shortage, especially licensed independent clinical social workers. For example, this committee has heard how the school-based behavioral health expansion program is struggling to recruit and retain licensed clinicians. Children's Law Center's clients consistently report being unable to find providers offering the services they need. If they do connect with a provider, the wait for an appointment is often prohibitively long. The district has an additional imperative through Medicaid to maintain network adequacy. Under federal rules, DHCF must ensure access to services through a sufficient field of behavioral health providers. So we see how the overall success of government investments and programs and our residents' health all depend on getting social workers in the field. We ask the Board of Social Work to actively align its activities with this district-wide goal. The Board of Social Work has largely effectuated its mission to protect resident safety by restricting the professional population. The scope of the mission has been individual, which may be at odds with the broader systemic impacts of a limited workforce. We believe that when provider networks are functionally inadequate, that is a patient safety issue. When clients lose their trusted therapist to turnover, that is a patient safety issue. If patients are not getting the right therapies from specialized providers or can't communicate in the same language, those are safety issues. If the district's emergency departments are treating patients in crisis because they are waiting on months-long wait lists for services, that is a patient safety issue. We recommend the board encompass workforce development and the remediation of obstacles to licensure as part of its mission. And there are a number of ways we could do this without jeopardizing service quality. The board could consider, for example, the data from the Association of Social Work Boards showing that 52% of Black exam takers in DC don't pass on the first attempt, compared to 93% of white exam takers. The ASWB declared the data a call to action for boards toward addressing the systemic and institutional factors that disproportionately affect Black licensure candidates and those of historically marginalized groups. Additionally, the board should reconsider policies that have the effect of restricting workforce capacity. For example, there are calls to extend the length of supervised practice that the board allows. It may also want to rescope the definition of unlicensed social work practice, which may unduly disqualify applicants from any social work or other licensure. In 2022, we asked the council to fund 3 additional FTEs to expedite licensing for social work and professional counseling. HRLA did receive funding for 10 licensing specialists, but its oversight responses noted that the Board of Social Work was granted 1 specialist only temporarily. There should be at least 1 permanent FTE added for the Board of Social Work with possible additional support for the 2 other behavioral health boards. Lastly, we detail in our written testimony how the board could participate in robust data collection and analysis. An assessment of the current workforce makeup is needed to determine gaps, inform policy and financing decisions, and to develop recruitment and retention strategies. In conclusion, we ask the Board of Social Work to align with many other DC agencies and programs working to ensure the behavioral health workforce is strong and sustainable, which will in turn improve the safety and well-being of people with behavioral health needs in our community. Thank you for the opportunity to testify today. I welcome any questions.
Thank you, Amber. Sue?
Hello, Councilmember Henderson and members of the committee. My name is Sue Brykoff, and I'm Chief Development Officer for Woodley House and a proud Ward 1 resident. Thank you so much for the opportunity to testify today. Woodley House has been providing supported housing and related services to DC residents with behavioral health disorders for 65 years. We operate 32 homes for more than 300 residents per year across 4 wards. We also operate a weekly food pantry for DC residents at our flagship location in Woodley Park. I wanted to take this time to point out our four core issues facing Woodley House and our sibling organizations with regard to degree holding and licensed social workers and our workforce in general. First, there are not enough LICSWs to go around. Councilmember White's proposed legislation to fund a graduate level social work program at UDC will certainly help this situation, especially since the current local programs draw students from around the country who don't tend to stay in DC. However, the results of this program are a long way off. In the short term, we suggest that the board look at what other types of providers could be supervisors, including LMFTs, LPCs, PAs, and RNs. Second, according to current regulations, only LICSWs can supervise social work interns. This is counter to other behavioral health professions like LPCs, which allow other professionals to supervise their interns. These interns are the bread and butter of our work and serve as a pipeline for future staff, but we are limited in how many interns we can take on because of who may supervise them. We suggest that the board allow at least some percentage of supervision hours be given to LPCs or psychologists. Third, the social work licensing exam, as my colleagues on this panel have spoken about, is deeply problematic. The success rate for people of color taking it is far lower than their white counterparts. Only about 45% of Black exam takers pass, as opposed to 84% of white exam takers. I'm sure you are aware of the petition that circulated last year. We ask that an investigation into the bias of this exam be conducted immediately. Last, and tying into the licensing issue, the requirements are currently such that social work program graduates must pass their licensing exams for positions that do not require a license. For example, we were thrilled last year to become certified by the Department of Human Services as a permanent supportive housing provider. However, we are still unable to hire qualified case managers. We appreciate that housing individuals from the coordinated entry list of homeless individuals is a top priority for the city, and we share that priority. The candidate pool is, in a word, tiny, but it is made even smaller by us not being able to hire unlicensed social work degree holders for a position that does not require a social work degree. Alleviating this requirement would make a huge difference in our ability to finally fill these open and critical roles. Behavioral health needs are only getting more urgent. Let's work together to eliminate at least some of these barriers. Thank you for allowing me the space to comment.
Thank you, Sue, and Will.
Good afternoon, Chair Henderson, council members, and council staff. My name is Will Doyle, LICSW, and I am the Director of Housing Operations at Housing DC. I've been attending the monthly Board of Social Work meetings since September 2022.
Hey, Will,
Yes.
I'm sorry. Your sound is coming in very muddled.
Okay. How's that now?
It's still breaking up. So I don't know.
All right, if I do the video off, is that better?
Unfortunately, it's not. And I'm only stopping you because I do want to hear, I want everyone to be able to hear the fullness of your testimony. Okay, now we can't hear you at all. You want to try to say something? Okay. We can't hear you. So how about this? How about you sign out and sign back in? Okay. And we'll just have you go on the next panel. So thank you to you all for being here. And I definitely want to hear what Will has to say. So I'm going to try to vamp a little and we'll get him on the next panel. And the fact that, you know, I've heard some of you present some of this testimony before. I want to ask this question. Late one night, kind of went down a little bit of a rabbit hole in terms of looking around the social work exam based off some testimony that you all brought up, some of you brought up in the behavioral health hearing. And one of the things I'm trying to understand is what is it specifically about this exam? Given that if we look at the exams of other professional licensing, nursing, medicine, pharmacy, the law, we see disparities in those exams in terms of passage rates as well. But there is not a full-throated campaign as we're seeing here for in those professions for folks to say we should get rid of the examination, say for nursing. Why do we feel that the social work issue is particularly unique from what we're seeing happening in some of these other professional arenas? Anyone can take that.
I would point out a couple things that I think are additionally concerning. One is, and of course we want all professions to have equitable staffing, but when we're addressing people who have complex social needs, who have maybe additional cultural needs, we want them to be served by people who look like and come from their community. And so I think that there is something about the nature of the profession itself that does lend itself to putting this under additional scrutiny. I would also note that the Association of Social Work Boards, in an earlier study that they haven't published, conceded that the test, while it has racial disparities, doesn't seem to have the same degree of disparities for people who train in the Midwest. And the disparities are exacerbated for people who train in coastal universities. I think that actually reflects the MSW programs and even BSW programs in coastal areas, more often in major urban areas, are doing a better job training cultural competency and other things that just aren't covered on the exam. And so the exam isn't necessarily the most relevant thing to practice. And so that, I think, is something else that kind of diminishes the importance of these exams. I would also point out that some of the other professions that you named are granting terminal licenses. RNs are capable of significant independent practice. Lawyers are expected to do significant independent practice. I think the biggest objections here are to lower levels of social work licensure, where we expect that the other portions of both their training before and their ongoing clinical supervision are going to make sure that these are professionals who are delivering care that's still safe, which is really why we have licensing requirements in place in the first place. Right.
So Illinois and California removed the exam requirement for their most basic licensure level. They call it the LSW. I guess in DC, that would be our licensed social work associate. But that doesn't solve the supervisor problem, which I understand from even Director Zeilinger is the issue. We can't find folks to do the supervision. So even if we took that element out, that doesn't necessarily solve all of the issues.
Oh, no, I mean, these are both and things.
Okay.
and I, the council is going to have to act around some of the supervision issues. The code is actually where some of the choices are made in terms of who can supervise for which kinds of work within the profession of social work. So that's not even something that the boards would have the discretion to make a change. We do need to look to the council to update the code as well.
Okay. I'm going to be over my time. So I'm going to I'm going to stop there. Councilmember Parker.
Thank you. Mr. Doyle, are you able to speak now?
Does my audio work?
No, it still sounds distorted. And I had a chance to speak with you, which is why I called. And I was going to also include you on this discussion. So maybe we can come back to you. Chairwoman Henderson will give you directions on that. But Mr. Lavoda, I want to pick up on where you were just discussing with Chair Henderson. If we were, let's say, to ease requirements around social work licensure, you're saying it's a both and. What would be the impact of that if we didn't necessarily fix in the short term the supervisor issue, which, well, let me end there. And I have a follow-up question, but what would be the impact if we did not address the supervisor issue that Chairwoman Henderson is flagging as well?
Yeah, so again, there are a couple different pieces to this. One is just entry to the profession. We know that we're losing people who want to work in the field of social work, who have completed degrees to work in the field of social work. And those degrees have required internships and practica. They've already been working in the community. We don't want to lose those people who are willing to do the work. In particular, that includes people who may even have a caseload. We have people who are studying in these programs who are also working for organizations. And the moment they complete their degree, they're not eligible to continue to work unless they have their license. And so we see that we have to reassign caseloads, which is not easy to do with the short staffing situations that we're already facing. So I think part of it really does just come down to those issues. I do think, though, that there's something important about updating the supervision parameters. We see that other boards are able to both ensure that professionals receive the distinctive training within those other disciplines, while also relying on independent practitioners that are in the broader field. The Board of Professional Counseling allows psychiatrists and psychologists and social workers to supervise people who are trying to become licensed professional counselors. The Board of Social Work doesn't have that kind of reciprocity. The Board of Professional Counseling also says 100 hours of people's direct clinical supervision, where they're observed, where they're reflecting on their day-to-day practice, has to be with a licensed professional counselor. They're still going to learn the particular things that are distinctive to that profession. So I think we just have to really be mindful of reaching a better balance between what we're looking for in terms of broad supervision and management, and how we make sure people are trained in their particular disciplines.
No, that is helpful. I would say I do think it is compelling when you look at the data that if something is off, then when you look at the stark racial divide of who is passing these exams. That said, I wonder if there's a third path. So we have our current path. There's a proposal to completely do away with the licensing exam. Is there a third path that, and I would love Ms. Breckoff or Ms. Recchi to speak to, where perhaps there is a wider span that one has to pass the exam if they're not successful on the first time, and maybe they come within X points from passing that may permit them to engage in certain baseline services. But yet they still have to take and pass the exam. Can you just speak to any variations that you may have seen or heard or proposals of the sort?
And I'm going to defer to my colleagues on the panel with this, because I do not have a degree in social work and have not gone through this. So I think, I can speak about the Woodley House experience, but, definitely want to hear from my colleagues.
I also am not a social worker, but I'm trained in public health and looking at data and health disparities. And when I look at that data, what I wonder is, what is it about this exam's relationship to whiteness that makes it so much easier to pass for white
But
folks.
to Chair Henderson's point, that argument can be made to assessments across the board, even down to K through 12. And that argument is made.
Yeah, and I'm not advocating to specifically do away with the requirement, but this is the conversation we're asking the board to have, and the Association of Social Work Boards nationally is asking boards to have. What is going on here? How can we make, in DC specifically, our workforce better reflect our community and the need?
That is my time. Mr. Doyle, I hope we do get a chance to hear from you. As a recommendation, maybe if you call in, we might be able to hear from you.
Yeah, I am on my phone now.
Oh, we can.
Can you hear me?
We can. So,
Okay.
Will, what we're going to do, if you just hold on a second. Mark, Sue, and Amber, thank you so much for presenting your testimony. We will certainly follow up. We'll be asking questions about a lot of these things. We are behind schedule. So I'm going to try to, what I'm going to do is I hate doing this, but I'm going to do this. I'm going to call literally all the rest of the public witnesses up because Dr. Anderson, who's the board chair for the Board of Medicine, has already joined us. And the thing about us having the board chairs as opposed to the executive directors is that they're actually practicing physicians in their various fields. And so I want to be mindful of their time because we did give them window estimates. So I'm going to move very quickly. So we'll have Will Doyle, Rachel Doyle, Karen Ostiel, Juanita Price, Valeria Carter, Betty Gentle, Dr. Chaudhry, and Kurt Gallagher. And while those folks are coming in, I'm just going to go ahead and get started. So Will, why don't you go ahead, and then Rachel, you'll follow right after him.
Okay. Yeah, thank you, Chair Henderson, council members, and council staff. My name is Will Doyle, LICSW, and I'm the Director of Housing Operations at Pathways to Housing DC. I've been attending the monthly Board of Social Work meetings since September 2022 after learning of the incredible disparities in the pass rates for the Association of Social Work Boards licensing exams. These exams are used by the Board of Social Work for all 4 types of social work licensing. I've also devoted myself to understanding this issue as much as possible. In doing so, I learned of concerns regarding the influence and power that the Association of Social Work Boards has over state licensing boards. I attempted to better understand the relationship between the Association of Social Work Boards and the DC Board of Social Work by submitting FOIA requests. A request for copies of all contracts and agreements submitted on 10/9/22 resulted in a response that the Department of Health had no such information, but also indicated the Board of Social Work is a member of the Association of Social Work Boards. I submitted a broader request regarding the relationship between the Association of Social Work Boards and the Board of Social Work on 10/17/22 based on this statement of membership, but that has still not been processed. Verbal communication by board members at the monthly meetings and their written response to testimony provided at the September and October meetings suggests full trust in the Association of Social Work Boards' efforts. This is despite years of refusing to release exam pass rate data and a statement by their CEO in December 2020 that they do not collect exam information on exam pass rates based on demographics. Based on their subsequent release of 10 years of such data, this has proven to be an incredible lie. Additionally, despite being a nonprofit, the Association of Social Work Boards increased their net assets by over $22 million in the period for 2011 to 2020, reflecting how they profit through their monopoly on social work licensing despite their flawed and biased exams. The DC Board of Social Work has consistently expressed the importance of ensuring social work competence and public protection through social work licensing standards while defending the need for an exam at each level of social work licensure. However, despite over 40 years of use, no evidence of correlation between passing the Association of Social Work Boards exams and both social work competence and public protection has ever been produced. All of this is to say that DC needs a strong Board of Social Work that is capable of independence from the Association of Social Work Boards as DC grapples with the issue of bias and worthless exams being a part of our licensure process, as well as the demands of our changing profession and world. Since September 2022, the Board of Social Work has been considering such important topics as extending the use of telesupervision, counting group supervision toward clinical licensure, and returning to in-person board meetings. However, the current board seems to lack capacity to fully address these issues in a timely manner. Topics have been repeatedly discussed at meetings without progress or reflecting work completed between meetings. Board members have expressed concerns about the quality of telesupervision without providing any objective data to support their conclusions. The discussion regarding group supervision displayed a severe lack of trust in licensed social workers accurately completing forms regarding supervision hours, and instead focus on board staff capacity to implement a change in policy. This is despite board members citing social work standards recommending that 50% of individual supervision hours towards clinical licensure can be completed via group supervision. I sincerely hope that this committee will use its role to fully explore the concerns I have shared and ensure that we structure, form, and provide ongoing oversight of our Board of Social Work for it to perform its function successfully and prioritize the needs of the District of Columbia over the Association of Social Work Boards. Thank you for holding this hearing. I'm happy to answer any questions.
Thank you, Will. Rachel?
Hi. Good afternoon, and thank you for the opportunity to speak today. I am a clinical social worker and have newfound interest in the DC Board of Social Work following the data release surrounding our profession's biased licensure examinations. I have been attending board meetings regularly since September. I've learned a lot over the past several months, and I wanted to let you know about my concerns related to the DC Board of Social Work. Their small size, they're biased towards the Association of Social Work Boards rather than DC residents and social workers. They're biased towards private practice rather than agency-based social work, and their obvious mistrust of social workers. I'm going to focus on their size. Repairing this would work to mitigate the damage of the other three. DC has over 6,000 social workers. The board currently has 4 members, an LGSW, an LICSW, an LISW, and a consumer member. They have not found an LSWA who is both willing and meets the requirements to serve for many years. Representation is very unequal. The LISW member represents less than 50 individuals, but the LICSW represents over 4,000. I would add that likely because there are so few LISWs to choose from, the same one has been in the position since 2012, when board appointments are usually only 2 or 3 years. From my observation, a 4-member board cannot effectively represent this number of social workers. Important issues move at a glacial pace. I've observed them talk about issues over multiple meetings, but make no decisions and not seek evidence-based information to make decisions. As a particularly egregious example, fellow social worker brought forth an issue to the board. It first appeared on the agenda in November 2020. It is related to services for minors who have been sexually assaulted. In February 2023, this issue still appeared on their agenda. I do not know more about the specific issue since it has always been a closed session agenda item, but I have grave concern that an item related to minors experiencing sexual assault has stood unresolved for over 2 years. I note that the board did not, however, have any challenge quickly shutting a group of us down who came to them with concerns about our profession's blatantly racist licensure exams. DC needs to robustly expand its Board of Social Work to include several more members. Licensure type is not a very important way to divide board membership. Either current or recent practice scope is far more relevant. Please ensure that social workers with a variety of practice scopes have representation on the board, not just private practice social workers. The board does not demonstrate that it represents the interests of nor have any curiosity about social workers doing agency-based work. This means it is missing the mark on ensuring that DC's most vulnerable residents have robust, high-quality services. It is also not helping to ensure that critical social services jobs are sustainable for social workers. Our most vulnerable DC residents desperately need a Board of Social Work that is knowledgeable of and responsive to the needs of social service agencies. Ensuring that there are always multiple social workers on the board doing agency-based work will ensure that the board serves the interests of all DC residents. Thank you, and I welcome any questions.
Thank you, Rachel. Karen?
Good afternoon, Chairperson Henderson and other members of the Committee on Health. Thank you for this opportunity to provide testimony related to the DC Board of Social Work. My name is Karen Ostley, and I'm a Senior Director at Catholic Charities of the Archdiocese of Washington in our Behavioral Health Services, also known as Anchor Mental Health Association. In addition, I'm an LICSW and a DC resident. In our behavioral health programs, we provide a full continuum of services to meet the whole health needs of both adults and children. Our services include outpatient mental health services through our freestanding mental health clinic, a full range of core services, assertive community treatment, supported employment, school-based mental health services, and children and adolescent mobile psychiatric services, also known as CHAMPS. I know all of you are acutely aware of the staffing crisis behavioral health providers are facing in the district. I'm asking the Board of Social Work to act now to work with Council to remove one of the known barriers to hiring qualified bachelor's and graduate level social workers by eliminating the need for the ASWB national exam as a means to licensure. Licensure exams are keeping hundreds of qualified and ready social workers from serving their communities. We know this because ASWB, after 40 years of testing, released demographic exam data. The results are worse than we thought. There are huge racial and other disparities that have allowed white social worker graduates to enter the field and left many social workers of color behind. From 2011 to 2021, white test takers in DC passed the master's level exam at a first-time rate of 98%, while Black test takers passed at a 56% rate and Hispanic Latinos at a 71% rate. You may be thinking, why would we lower standards just because there are outcome disparities? Doesn't this result in unprepared and ineffective social workers? However, this question is based on the false presumption that licensure exam outcomes predict or are related to quality of practice. In fact, there's no evidence that such a relationship exists. Eliminating exams would not be lowering standards. It would be acknowledging the false standards that are reinforcing racial discrimination and shortchanging our communities. The National Association of Social Workers just came out with a statement opposing the licensing exams after review of the data. Even without exams, graduate level social workers have a high bar for licensure. They must graduate from an accredited school of social work, obtain hundreds of hours of closely supervised direct practice work through internships, submit recommendations from LICSWs, and get a criminal background check. Even after licensure, they are required to practice under the direct supervision of a LICSW. Taken together, that is more than adequate baseline of training and competence and oversight when they are hired in our programs. In my role as Senior Director in our behavioral health programs, I have directly witnessed the impact of the exam requirement on our ability to hire and retain social workers, and it's contributing to the crisis in our city. We haven't been open for new intakes referrals for some of our programs because we haven't been able to hire and retain sufficient staff to provide the services. We know there are qualified candidates with social work degrees who want to work in our programs and provide community-based services, but our hands are tied if they haven't been able to get licensed because of the racially biased ASWB exam. I've personally supervised individuals who worked in our programs, went back to school to earn a master's in social work, to advance their knowledge to better serve our clients, but have been forced to leave because they haven't passed the exam and then can't work without a social work license. These have been some of our best staff as they demonstrated they have the desire, experience, and education and come directly from the communities of the people we serve. Who better to make a positive impact in the lives of our clients? To close, the Board of Social Work and City Council must act now to remove the ASWB exam requirement. By doing so, DC will add qualified, competent, and ready social workers to its workforce and better serve our most vulnerable residents. Thank you, and I can answer any questions that you may have.
Thank you. Juanita Price.
Good afternoon. Thank you for the opportunity to testify today. My name is Juanita Price, and I am the CEO of Hillcrest Children and Family Center. Hillcrest provides comprehensive behavioral health services for including substance use disorder, mental health, school-based services to 30 schools, housing, and supportive employment. Hillcrest has served children and adolescents and families in this community since our founding in 1815 by First Lady Dolly Madison and Marcia Van Ness to provide services to orphans of the War of 1812. I'm also a very proud Ward 5 resident and homeowner. The scope and control of the Social Work Board is too broad and provides unnecessary barriers to practice. The interpretation of its roles and rules decreases the number of committed and qualified persons who can provide necessary services. Current rules set up artificial barriers, which can unwittingly promote discrimination and construct barriers for racial minorities and people of color to enter the practice. These practices contribute to the disparity in access to the behavioral health care for poor Black and Brown people. These practices contribute to workforce shortage and endangers our most vulnerable citizens who bear long lines, waiting lists, the consequences of unmanageable caseloads, and lack of provider continuity due to significant turnover. So what can be done about this? There's a song that says, you gotta be bad, you gotta be bold, you gotta be wiser. Individuals graduating from accredited school of social work, completing proper internship hours, should be able to practice social work under the supervision of independently licensed social workers, as already been testified to. Individuals who are not social workers, but work in private or governmental social service agencies that provide referral, advocacy, mediation, consultation, administration, education, community organization services should not be under the auspices of the Social Work Licensure Board. Individuals with a social work degree are prevented from providing care coordination, community support, as they are deemed to be practicing social work without a license. As Karen just spoke to, once you get your master's, there's nothing for you to do if you don't pass the exam. But we know that there is a lot for individuals to do. Hillcrest provides a crisis service to vulnerable youth and families called community-based intervention. This program is designed to keep youth involved in multiple systems out of jail, provide intensive community crisis care, and support the youth in a least restrictive environment. We prevent out-of-home placement, incarceration, school expulsion, unnecessary psychiatric hospitalization. National experts, local providers, and even influential staff at DBH this past year agreed that this service could be best provided with a team approach that included a licensed counselor or social worker, as well as a well-trained, skilled support professional. The Social Work Licensure Board determined that all persons providing CBI services had to be licensed. Therefore, staff had to be laid off, services had to be cut. We were not able to provide the services in the way that we needed to. We gotta be bad, we gotta be bold, we gotta be wiser. The workforce shortage for behavioral health professionals is real. Today, there are more security guards in our children's schools than social workers. Washington is home to just over 700,000 people and approximately 3,500 social workers. Some states offer career paths for their residents who are interested in social work, like Michigan, Ohio. Registered social service technicians or registered social work assistants are afforded a career path. In comparison, the nursing profession offers career paths and gateways for professional nurses. Much has been said that I wanted to speak to, so I will not reiterate what has already been said. But I will say again and emphasize the scope and control of the Social Work Board is too broad. It is my hope that the issues raised here today will bring about administrative and legislative remedies to address the issues raised by today's testimonies. We are facing a crisis. I believe the Board of Social Work can offer some solutions, but the solutions gotta be bad, they gotta be bold, and they got to be wiser. Thank you very much.
Thank you. Valeria Carter.
Good afternoon, Chairman Henderson and members of the council. My name is Valeria Carter, and I am the Senior Clinical Administrator of Clinical Practice at Hillcrest. I am an independent social worker, licensed social worker. I'm also a proud social worker for over 30 years, and I'm a DC resident who lives in Ward 5. And I'm echoing some of the same sentiments that my colleagues have echoed. The social work boards requiring potential social workers graduating from accredited college or university be required to sit for the graduate ASWB license exam has been a huge barrier for potential social workers. According to the National Association of Social Work Board's data has shown that the exam is biased toward not only social workers of color, but also older potential social workers and those who speak a second language. There are unlicensed social workers who are very diverse. I know some, eager to provide sound practice, can identify solutions, be creative, and advocate for the residents and individuals and communities in the District of Columbia who are in dire need of services. There's a shortage of social workers in the District in Columbia. This policy has exacerbated that service, the need for that service and that shortage of social workers. It has been very difficult to fulfill critical positions due to the shortage. We have social workers who have heavy caseloads because we can't find enough social workers who have a license to be assigned those workers. Social workers graduating with a master's degree program or a bachelor's degree program do require internship or practicums. And I think that should require a potential social worker, not to have to sit for the licensure or graduate licensure exam. And they are supervised by a licensed social worker. I think we should also consider another reason to remove the licensure exam is to incentivize non-licensed individuals to begin a trajectory path into the social work profession by removing those barriers. We must strategize ideas to come together to look at strategic approaches to remove those barriers for potential social workers so that they can do the work that they've been called to do. And there are a lot out there. And so thank you for this opportunity. I didn't want to repeat a lot. So some people have already said and spoken, and I just want to say that. And I myself have found the test to be very biased and outdated. Thank you so much for this opportunity.
Thank you. Betty?
Dean Chairperson Henderson and members of the committee. My name is Betty Gentle, and I'm a Senior Advocacy and Community Engagement Specialist at SUM Incorporated. Thank you for the opportunity to testify. Since 1970, SUM has been working to break the cycle of poverty, homelessness, and hunger through our comprehensive whole person approach, which includes offering physical and behavioral healthcare services through a variety of settings, including our FQHC clinic sites, community and in-home services, transitional housing programs, and residential treatment programs. SUM believes that every DC resident deserves access to high-quality, person-centered healthcare, but this is made much more difficult when healthcare providers don't have the workforce that they need to offer these services. SUM commends the Board of Social Work for working with us and allowing social work graduates to practice under a supervised letter and creating an online licensure application process. Still, we believe that the board can help alleviate barriers to hiring by addressing the following. First, reduce the long delays in the licensure process. Applications being processed by the Social Work Board as well as the Nursing Board are extremely delayed. For example, it took 6 months for one applicant's nursing board transfer application to be approved. This interferes with this person's ability to make a living, and it impacts providers' capacity to serve more DC residents. The Board of Social Work has been open to communicating about these worrisome delays and has reported that they are caused by incomplete applications. However, in our experience, this has not been the case for every applicant, some of whom must wait for an extended period of time. Some hope that now the applications are required to be submitted online, the application process will be more efficient and will generate a larger hiring pool of qualified applicants. Second, make the practice under supervision license more accessible and effective. Now that supervised practice has been approved, improvements are needed to have a real impact on reducing workforce barriers. First, we recommend streamlining the process. Applicants seeking a supervised license letter are also experiencing the processing delays previously described. For instance, SUM currently has a candidate who has pursued the letter of supervised practice, but it appears that she still must undergo the standard licensure application process with the same wait time. Second, we recommend allowing graduates more time to practice with a supervised license. We recommend extending the time of supervised practice from 90 days to 20 days. We also recommend allowing more than one renewal period for applicants who failed the national exam if it is retained, but are studying to retaking it. Third, eliminate the national social work exams that are producing racially inequitable outcomes that are hindering diversity in the social work profession. In 2022, as many of my colleagues have already talked about, the Association of Social Work Boards released the data to show that Black and Brown graduates across the country passed the licensing exam at an alarmingly lower rate than their white counterparts. As these exams are not nationally required, DC's Board of Social Work can disrupt these racial inequities by eliminating these standardized testing requirements at the non-clinical bachelor's and master's level. For instance, the Illinois chapter of the National Association of Social Workers was successful in advocating for legislation that removed its ASWB test requirement for the non-clinical master's level in 2021. This resulted in almost 3,000 newly licensed social workers in the first 6 months of 2022, compared to only 421 social workers during the same time period in 2021. We encourage the Social Work Board to assess the many other models and various options around the country and identify other best practices to ensure that candidates are appropriately qualified to practice that do not have a disparate impact on Black and Brown aspiring social workers. And last, narrow the social work scope of practice definition. The Board of Social Work has periodically issued disciplinary letters and imposed fines on unlicensed people who have worked in the health and human services field before completing their Master of Social Work degrees while applying for their license on the basis that their prior work constituted unlicensed social work practice. The current definition of the scope of practice allows the Board of Social Work to exercise authority over a range of activities that are regularly carried out by a variety of persons without applying social work methods, such as case management, outreach, administration, and even advocacy. However, because the board can only limit the activities of licensed persons in DC, individuals with such community-based work experience that often translate well to a career in social work are less likely to seek a social work degree or license or do so in DC to avoid being fined or deemed ineligible altogether for their license because of their previous work experience. Some appreciates the opportunity to offer these comments and looks forward to continuing to work with the Board of Social Work and providers to strategize ways to stimulate growth in the workforce. Thank you.
Thank you. Dr. Chaudhry?
Thank you, Chairperson Henderson, for your leadership, and thank you to the committee. My name is Dr. Hank Chaudhry, and I am the President and CEO of the Federation of State Medical Boards. I'm speaking to you from our DC office. On behalf of the FSMB, I'd like to thank you for the opportunity to speak about the importance of the DC Board of Medicine and its value to the FSMB. The FSMB is a national nonprofit organization representing all 70 state medical and osteopathic licensing and disciplinary boards of the United States, its territories, and the district. Since its founding in 1912, FSMB has supported state medical boards as they engage in their statutory mandates of protecting the public's health, safety, and welfare through the proper licensing, discipline, and regulation of physicians and other healthcare professionals. The DC Board of Medicine is an active member of the FSMB and is well respected among its fellow medical boards across the country. Many of FSMB staff call the district home and benefit daily from the important work being done by the Board of Medicine. The board has been a leader nationally on a number of important issues impacting medical regulation and public health. In response to a national physician shortage, as one example, the Board of Medicine is working to facilitate licensure portability, which we've heard during the testimony, to bring more providers into the district to increase access to care for DC residents. With the support of the Board of Medicine, DC joins 38 other jurisdictions as a member of the Interstate Medical Licensure Compact. Once fully implemented in the district, the compact process will provide an expedited pathway to licensure for physicians who wish to practice in DC. The Board of Medicine is also committed to addressing healthcare worker well-being. The board has been supportive of FSMB's policy on physician wellness and burnout and has taken good steps to identify resources and strategies to better support the well-being of licensed healthcare professionals in the district. I would like to particularly commend the Board of Medicine's commitment to educating DC residents and future physicians about the important role the board plays in regulating medicine and protecting patients. Under the leadership of Board Chair Dr. Andrea Anderson, whom you'll hear in a moment, the Board of Medicine is frequently out in the community, engaging with residents and medical students to raise awareness of the board's work. The involvement of the DC Board of Medicine and its staff has been integral in the success of my organization in addressing the issues faced by all of our nation's state medical boards. Over the past decade, members and staff of the DC Board of Medicine have held prominent leadership positions on FSMB's board of directors, including Dr. Jacqueline Watson, Chief of Staff to the DC Department of Health, Dr. Anderson, current chair of the DC Board of Medicine, and Mr. Frank Myers, former executive director of the DC Board of Medicine. I thank the members of the Committee on Health for recognizing the critical role played by your Board of Medicine. Your continued support of the board will benefit patients and help enhance the safety and quality of medical care in the district. Thank you, and I'd be happy to take any questions. I abbreviated my remarks in the interest of time. Thank you.
Thank you, Dr. Chaudhry. And I will have some questions if you could just hang on. Kurt?
Good afternoon, Chairperson Henderson and members of the council. Thank you for the opportunity to testify today, and thank you for holding this hearing on the medical licensing boards. I want to focus in on one of the biggest challenges that dental professionals are facing in DC, and that is actually securing a license to practice. I understand that Mayor Bowser had the Healthcare Workforce Task Force, and first of all, the dental committee was not involved in that task force, so we weren't able to provide input on the recommendations. But one of the points I've made at DC Health as the task force was being announced is that those efforts ultimately will fail if people can't get licensed once they come to DC or want to come to DC. So I want to just share with you some of our recommendations. I'll share additional details in my written comments. First, there are a few statutory barriers that the council actually has the ability to control in effect. One is the licensing compact. There is a new licensing compact both for dentists and dental hygienists. It was finalized last year. And we would call upon DC to join that compact. So that way it will be launched and would make the licensing process more efficient in DC. In DC, dental assistants, all dental assistants are required to be licensed. And this is actually out of step with our neighboring states, which only require licensure of assistants who perform advanced functions. So that's something I would encourage the council to take a look at, that disparity in terms of that licensing process. The clean hands requirement here in DC, which does create additional barrier for potential applicants for securing a license. There's actually a disparity between the licensing fees in DC and in Virginia and Maryland, and that's something else I would encourage the council to take a look at. And then finally, there's a prohibition in DC on externships for those who are in training programs to be dental assistants, dental hygienists. If that were removed, it might actually expedite the process of training, but also incorporate people who are in the educational programs, get them to establish roots here in DC. So when they decide whether they want to have their license, they'll be looking at DC instead of our neighboring states. And also taking a look at the slow process to approve new training programs. I'm aware of at least 2 DC Dental Society members that have put together proposals to establish training programs for dental assistants, but those proposals, I understand, are still pending approval. And it's been months since they were submitted. I want to home in, though, on the actual licensing approval process, because this is a real linchpin. We've heard from other people testifying today about other boards, and the same holds true for the Board of Dentistry. Applicants may not submit a perfect application. They may be missing some documentation when they submit their application. But the problem is, once the application is submitted, they get virtually no feedback on the status of the application. We have a steady stream of applicants, dentists, dental assistants, dental hygienists, who come to us asking for help because they've gone to the Board of Dentistry, to DC Health, to request clarification about what the delay is, and they wait days, weeks, sometimes months to get an answer. I am happy to report that there have been cases where we've elevated these cases up to the executive director of the Board of Dentistry, and action's been taken. But these applicants shouldn't have to come to us to get that level of service, and they shouldn't have to wait weeks and months to have answers to basic questions about what might be missing with their application so they can complete it and so that it can be assessed fairly. And I'll share with you one anecdote that came to our attention last year. There was a dentist who'd been practicing in DC for nearly 3 decades. She applied for a license after the initial deadline last year, but when she finally came to us, she'd been waiting 7 months for her application to be approved. And then for some inexplicable reason, after she got a very detailed list of all the deficiencies in her application, one of the requirements that was placed upon her is actually to go get fingerprinted again, someone who's been practicing in DC for 30 years. After that point, it took almost 5 weeks for her to secure her license. The process at DC Health for reviewing and approving these applications, it seems to have serious deficiencies. I don't want to lose track of progress that's been made, though. So with the new, relatively new health licensing portal, a large percentage of our applicants were approved essentially automatically when they submitted their application. So I think that's a success we don't want to lose sight of. We also don't want to make changes to the licensing portal that would upset those who get that process of approving those license applications automatically. But I am concerned about those who are waiting, sometimes weeks and months, for action on their application. We do have some additional recommendations which we can share in our comments, and they relate to statistics to evaluate performance. Thank you for the opportunity to speak.
Thank you. We're going to do a 5-minute round here, and I apologize. I want to say, first off, thank you so much to everyone who testified. Kurt, we had to, as you know, we have a lot of boards, and we had to make a decision on who we call for this first hearing, but our intent is to work our way through them all. So I hope you come back for the Board of Dentistry. But if we don't have your written testimony, for all of you, if you don't mind, please submitting that for the record, because I think a lot of you had some really good recommendations in terms of some things that were very specific. Dr. Chaudhry, I wanted to start with you. So, of the boards that we have before us today, they all have vacancies. The Board of Medicine has 7 vacancies. The Board of Nursing has 5 vacancies. Pharmacy has 2 vacancies. Psychology has 2 vacancies, and the Board of Social Work has a vacancy as well. Are other boards around the country also experiencing this challenge of getting folks from the profession who want to do this work?
Thank you, Chairperson Henderson. I don't have hard data in front of me, but I have seen a trend. I've actually, over my 14-year tenure on the FSMB, I've been to all 50 states. And in recent years, there has been a significant turnover in staff, as well as those who serve on state boards. It could be multifactorial. Certainly COVID-19 had a role to play, but I think it's not always a job that's understood or appreciated by the public or by legislators. So it's not always been easy. But I know the DC board runs a tight operation in medicine. I know I can't speak for the other boards, but we're happy to help at the FSMB in any way that we can. But as you know, every territory has its own process.
Right. I know for perhaps maybe not all of the boards that are before us today, I'm going to ask some questions of those chairs, but one of the issues that we have, at least for the boards who don't have authority within their executive director to be able to approve applications, is that if the board can't have quorum, then you have a stack of applications that can't be approved. And so I guess I'll put a call out for all the folks on here. If you know some, folks who qualify for some of the open seats, like for instance, I think for the Board of Pharmacy, it's consumers. The 2 consumer seats are vacant, right? That doesn't actually require anyone to have a degree. It just has a requirement that you go to a pharmacy every now and again, which I think is actually fairly relevant. And so I'm putting out this call to anyone who is interested to contact MODA to sign up for this, because I think that is part of the process as well. Mr. Gallagher, you brought up something that I think I've heard before, but didn't necessarily kind of dig into, which is like the licensing fee disparity between the 3 jurisdictions in the region. Do you happen to know what the numbers are?
I can send them over to you. They're complicated. They depend on if someone's applying for initial application or renewal and sort of the level. So I can send it to you so you take a look at them. It's a little bit difficult to interpret because there's so many different numbers and variations.
Okay. I think that would be helpful just in terms of even when we think about compacts, right? It is the state that you originally go through that gets the licensing fee. And so we don't want folks to decide like, oh, I'm going to go through the Maryland process because it's cheaper or whatnot. We still want folks to be able to, or we still want folks who want to choose the district as their base for licensing for things going forward. Let me see. Ms. Gentle, you brought up some, I think you testified at an earlier Committee on Health hearing, perhaps. And if not, then I'm confusing you with your twin, but I'm pretty sure that you did.
That was me.
Okay. And in terms of bringing up the processing delays, and we'll ask some questions about that as well. Although some of that is, I think, probably more suited for conversations we'll have with DC Health on Thursday around how they decide how to assign staff to the various boards, because we got a chart, and for some instances, right, there's not even a full-time person. It's a 0.3 of a person, and the licensing piece is only a portion of the work that they do. They also are responding to complaints and all these other different types of things. But I hear you all in terms of, I think a number of people have made some recommendations around needing to increase call center or customer service staff of folks who could just ask general questions. One of the things I raised to DC Health was around just like a revamping of the website so that someone can very easily see like what are the rules of the road in terms of what they're needed. But I'm going to stick to my time. Councilmember Parker, are you with us still?
I am, but unfortunately, I don't have any questions for this panel. But thank you all as I'm jumping in between several panels.
Okay. Thank you all again for your testimony. If we don't have your written testimony, please make sure that we have it. But thank you all for being here. Okay, so in an effort to try to catch up, if I can, while I originally planned to call each of the boards separately, we're going to have to put some people together. So I'm going to call Dr. Andrea Anderson, who's the board chair for the Board of Medicine, and Midi Bardanil, who is the board chair for the Board of Nursing. We'll have you come together. And I think, oh, okay, everybody's at the same computer. Okay. All right. And to the public witnesses, we are putting you back as an attendee, but thank you again for being here. Dr. Anderson, good afternoon.
Good afternoon. Go ahead.
Yes, you can go ahead.
Okay. Good afternoon, Chairwoman Henderson, members of the Committee on Health and staff. My name is Dr. Andrea Anderson, and I'm the chair of the District of Columbia Board of Medicine. On behalf of Mayor Muriel Bowser and DC Health Interim Director, Dr. Sharon Lewis, I am pleased to provide this testimony on the achievements and planned activities for the Board of Medicine in fiscal years 2022 and 2023 to date. I should also mention that I'm a proud Ward 5 resident, and thank you to DC Health for allowing myself and my fellow board chairs to testify from their headquarters this afternoon. Having served on the Board of Medicine for over 10 years, I've had the honor of being appointed as chair of the board by Mayor Muriel Bowser in 2017. I am also a member of the Interprofessional Board Chair Collaboration, or the IBCC, which is a group of 7 hardworking DC Health Licensing Board chairs. My fellow board chairs in dentistry, nursing, pharmacy, social work, psychology, and professional counseling meet with DC Health leadership on a quarterly basis to advance DC Health's 4th strategic priority. This is closing the chasm between clinical medicine and public health. Together, we collaborate and learn about public health priorities and the inner workings of DC Health, and serve as ambassadors and advocates for advancing population health within the district. Outside of my service on the Board of Medicine, I currently serve as the Associate Chief of the Division of Family Medicine for the GW Medical Faculty Associates. Prior to that role, I worked in a variety of leadership capacities for Unity Healthcare, which is a multi-site federally qualified health center in the district. I also serve as an at-large director for the Federation of State Medical Boards and a board member for the American Board of Family Medicine. In response to the COVID-19 pandemic, I was appointed to DC Health's Scientific Advisory Committee to ensure the development and implementation of a safe, effective, and equitable COVID-19 vaccine distribution program in the District of Columbia. I've been a practicing physician for over 18 years after graduating from Brown University School of Medicine. Board of Medicine's mission is to protect and enhance the health, safety, and well-being of District of Columbia residents by promoting evidence-based practices in health regulation,
high standards of quality care, and implementing policies that prevent adverse events. One of the Board of Medicine's core functions is to license and certify healthcare professionals seeking to practice in the district. The Board of Medicine accepts application for medical licensures through 3 processes: national examination, an existing or previous United States license, or medical licensure from another country. The Board of Medicine also works to ensure continued quality of care through investigating complaints. Its disciplinary processes were developed with a focus on patient safety and provider accountability. The Board of Medicine carefully evaluates complaints from healthcare consumers in the district and conducts a comprehensive process to determine whether or not disciplinary action is warranted. Given the evolving nature of the medical field, the Board of Medicine regularly reviews and updates current covered scopes of practice. The Board of Medicine leans on its own expertise to identify and implement needed changes to the district's medical scope of practice. These changes promote innovative medical practices and improve population health within the district. The Board of Medicine also actively participates in community engagement opportunities with students, healthcare providers, and professional advocacy organizations. This engagement promotes accountability, transparency, and meaningful collaboration in driving the medical profession forward in the district. As the chair, I'm proud of the commitment of our volunteer medical board members and DC Health staff to make the commitment that they make to ensure that our licensure processes are executed in a timely and thorough manner. As of January 25th, the Board of Medicine oversaw 14,000 licensees across 15 licensure types, including medicine and surgery, physician assistants, and medical training licensees, just to name a few. Through their licensure, these professionals serve in healthcare settings across 8 wards and are committed to improving the health and wellness of all district residents. As a physician who currently practices in Ward 5 and has served in federally qualified health centers for over 15 years, I work to address healthcare disparities that exist in healthcare, specifically across the district. Most primary care shortage professional areas in the district are in wards 5, 7, and 8. And there is currently only 1 hospital east of the river. The Board of Medicine is fully committed to implementing strategies to address this need for physicians, including specialists in these communities. One such strategy is the promotion of the Healthcare Workforce Survey among our licensees. This survey provides DC Health's Community Health Administration with a greater understanding of the needs of the healthcare workforce, which in turn allows for improvements to programs such as the Health Professional Loan Repayment Program, which brings providers to high-need areas by providing loan repayment support. Several active projects and initiatives by the board to address the district's healthcare system include: 1, implementing new license types, such as athletic trainers, doulas, and certified professional midwives. Another initiative is implementing pathways for expedited licensure and licensure portability, including through a process of regional reciprocity. The Board of Medicine is also working to strengthen the workforce by addressing the effects of the COVID-19 pandemic. Providers across the healthcare industry have faced burnout and increased stress because of their professions. As a result, the Board of Medicine is committed to equitable solutions that promote long-term recovery from the pandemic. The Board of Medicine has placed an emphasis on better understanding licensee wellness through that healthcare workforce survey that I mentioned. These results will inform prospective strategic initiatives for the Board of Medicine and may result in new partnerships with relevant stakeholders. The Board of Medicine is also addressing emerging ethical issues for its existing licensees. This includes the development of policies around things like misinformation and disinformation by licensees, and refining the ability for licensees to self-prescribe or prescribe to family and friends. These revised policies will raise standards of care and enhance patient safety here in the district. Finally, I would like to underscore the challenge, as you've mentioned, that the Board of Medicine faces in working on these important initiatives due to current board vacancies. I understand that several nominations to the Board of Medicine are being processed, and we urge the council to approve them as soon as possible. Finally, I want to wholeheartedly thank the Committee on Health for their continued support of the district's healthcare workforce, including the recent support for creating a new advisory committee on maternal health professions. Thank you. As well as additional funding for health licensing specialists. Those are the staff members that process those 14,000 licensees that I mentioned. So that we had an increase in that funding in fiscal year 2023. So thank you. I definitely appreciate this opportunity to testify, and I look forward to any questions that you may have for me at this time. Thank you.
Thank you, Dr. Anderson.
She's here.
Oh, is she? Okay.
She's right here. Or I can take her questions, whatever you
okay.
prefer.
Well, I don't know if you have a time constraint. We're
here together. So
okay.
I can pass it on to me. Oh.
Hi, good afternoon.
Good afternoon.
Good afternoon, Chairwoman Henderson, members of the Committee on Health and staff. My name is Meedy Barnelli, and I have the honor as serving as the chair of the District of Columbia Board of Nursing. On behalf of Mayor Muriel Bowser and the DC Health Interim Director, Dr. Sharon Lewis, I appreciate this opportunity to share testimony with the committee here today and always speak about my profession of nursing. And I'm pleased to offer an overview of the Board of Nursing's accomplishments in fiscal year 2022 and fiscal year 2023 to date. I also want to take a moment, Councilmember Henderson, to give a shout out to Dr. Terry Walsh and all of the amazing staff that support the Board of Nursing, because there's nothing we can do without them. The mission of the Board of Nursing is to safeguard the public's health and well-being on assuring safe quality care in the District of Columbia. This is achieved through the regulation of nursing practice and our educational programs, and by the licensure, registration, certification, and continuing education of nursing personnel. Through all of these efforts, we advance equity and improve population health throughout the District of Columbia. And as my fellow chairperson just mentioned from the Board of Nursing, I too am a proud Ward 5 resident. Through these efforts, we advance equity and improve population health throughout the district. In addition to serving as chair of the Board of Nursing, I am also a member of the Interprofessional Board Chair Collaboration, the IBCC, which is a group of 7 health professional licensing board chairs. My fellow board chairs include dentistry, medicine, as you've just heard from Dr. Andrea Anderson, pharmacy, social work, psychology, and professional counseling. And I meet with the DC Health leadership on a quarterly basis to advance DC's health 4 strategic priorities: closing the chasm between clinical medicine and public health. And together, we collaborate to learn more about public health priorities and the inner workings of DC Health, and serve as ambassadors and advocates, more importantly, for advancing population health in the district. I am also currently a nursing director of surgical oncology at the MedStar Washington Hospital Center, and I'm also the president and founder of the Black Nurse Collaborative, which works to address inequities in the nursing profession through collaboration and professional development. I have worked in the field of nursing for over 17 years, and I'm a proud graduate from the Howard University with a Bachelor's of Science in Nursing and a Master's in Nursing Management and Leadership from Jacksonville University. I began my first term on this amazing board, which I personally think is the best, of nursing in 2017, and quickly moved into the role of interim chair. After serving years as the interim chair, I was then confirmed as a permanent chair in 2022. And as chair of the Board of Nursing, I also had the ability to serve as a member of the National Council State Boards of Nursing Subcommittee on NCLEX site and reviews. The nursing fulfills critical responsibilities to ensure the board can perform with a focus on quality, safety, and efficiency. And as chair for the Board of Nursing, I coordinate and lead our bi-monthly meetings, and I ensure that all parties before the board are treated with equality, and also that our public have a forum to share any of their concerns. The Board of Nursing serves as an important role in advancing the healthcare workforce of the District of Columbia. Through 8 unique license types, the Board of Nursing oversees over 49,000 dedicated health professionals and nursing assisted professionals. The Board of Nursing and its staff work diligently to ensure both the public and its licensees are kept safe. We make sure that licensees are equipped with the knowledge that they need to continue to provide valuable, life-saving care through continuing education. These requirements ensure that nursing professionals keep up to date with best practices of their professions and are aware of emerging health issues, such as COVID-19. When residents or visitors experience an issue related to poor or unsafe quality care of nursing professional practice, the Board of Nursing quickly investigates and, when appropriate, takes disciplinary action to correct the issue. This can include issuing a notice of intent to discipline, suspension, or a revocation of its license. The Board of Nursing also serves a critical role in developing the next generation of nursing professionals. And as one of the regulating entities for nursing education programs, the Board of Nursing makes sure these programs offer high quality education and prepare nursing professionals for the important role they will serve in our healthcare system. Staff and the Board of Nursing members work diligently year-round, I repeat, year-round, and sometimes on their weekends, to ensure that professionals receive their licenses in a timely manner. And as of February 8th, 2023, the Board of Nursing oversaw the licenses of, and please get your pens out, ladies and gentlemen, 4,806 certified nursing aides, 147 certified nurse midwives, 36 clinical nurse specialists, 7,874 home health aides, 1,839 licensed practical nurses, 3,182 nurse practitioners, and 29,771 registered nurses, of which only a few are actually DC residents, I might add, and 155 registered nurse anesthetists, and 1,390 trained medication employees. So if you do the math, that's over 52,000 individuals that Dr. Walsh and her staff work diligently and tirelessly to make sure they get licensed. So additionally, the Board of Nursing is responsible for oversight of the district's 15 nursing educational facilities. While the pandemic has had a profound impact on the nursing workforce in the district and across the nation, the district saw a 5% increase in professionals under the scope of the Board of Nursing between 2019 and 2022. Some of these nursing professionals, however, were from staffing agencies serving short periods of time so that these members could be interrupted with some caution. Within the district, there is a projected job growth of 37% in entry to intermediate skilled healthcare professionals, which includes many professions that go underneath the scope of the Board of Nursing. And this was between 2016 and projected to 2026. Given this projected need, the Board of Nursing continues to evaluate strategies to make the nursing profession more accessible to a diverse spectrum of aspiring professionals. Nursing professionals are the backbone of the healthcare system. And I'll repeat, nursing professionals are the backbone of our healthcare system. Again, we are for the 21st consecutive year rated the most trusted profession. And nurses make up the largest share of healthcare professionals, with over 4 times as many as my fellow colleagues, the physicians, and we do love them. But we spend a significant amount of time at the patient's bedsides, and we are the front line of healthcare delivery. So over recent years, the role of nursing has become more integral in the healthcare system as nursing professionals have taken on many larger responsibilities. This includes recent clarifications to the authority for advanced practice registered nurses to sign or certify all documents that require the signature of a physician. However, the nursing workforce is facing several threats, as I'm sure we're all aware of. According to a recent survey of frontline nurses conducted by McKinsey, 22% of nurses surveyed asked and shared that they were seeking to leave the most trusted profession. Unfortunately, as the COVID-19 pandemic disrupted the healthcare workforce, the district must continue to address its nursing shortage through the development of robust pipelines to our profession. This includes continued and enhanced support for our faculty, clinical sites, and nursing students, and yay, I might add, my fellow colleagues here at DC Health that do the work behind the scenes. Additionally, we must ensure that nursing professionals have the pathway and the tools to achieve meaningful career progression. As board chair, I am committed to continuing to focus on these important needs and to identify new and innovative strategies to advance the nursing profession. The Board of Nursing is continuing to work to expand the supply of nursing professionals for the district's growing healthcare workforce needs. This includes implementing new license types, which include dialysis technicians, patient care technicians, and medication aides, all to address the evolving needs of our healthcare system and to expand the healthcare team. The Board of Nursing has also made technical improvements to enhance access to licensure. All applicants for professional licensure through the Board of Nursing have shifted, thankfully, from paper to electronic process. And the Board of Nursing's website has been regularly updated to ensure necessary information is both accessible and ready for our public to achieve. The Board of Nursing is currently working to update its advanced practice registered nurse and our LPN regulations to reflect modern practices and to expand their scope of practice. These efforts are an important step to strengthening and continuously improving the standards for the district's nursing workforce. I look forward to continuing to work with my fellow board members to advance the profession of nursing and the field of nursing here in the District of Columbia. I would also like to thank again you, Committee Council Member Henderson, and the Committee on Health for your continued support of nursing and the district's healthcare workforce, including additional funding for licensing specialists, please, in the fiscal year 2023. I appreciate your time and this opportunity to testify before the Committee on Health, and I look forward to any questions you might have for me at this time. And also, may I take a moment of privilege to say thank you to our director, who's also a nurse, in the person of Dr. Sharon Lewis.
Thank you. Okay. So I think we might figure out the logistics here.
I think we can kind of scoot next to each other, Councilmember Henderson, if that's okay. Is that okay?
Oh, that works for me, if that works for you guys. Now, Ms. Bardinil, you know, we're not going to do the tit for tat of whose board is best.
It's okay. I know, it's okay.
But I want to thank you both for being here. One of the things that, you know, I think often people talk about the boards and sort of this ominous, like the boards, but we haven't actually heard from the boards in quite some time. And so I appreciate you all testifying, and as well as the Department of Health for providing some information around the activities and the work that you all have been doing. I want to first start with a question that I had asked Dr. Chaudhry, who's the president of the Federation of State Medical Boards, around vacancies. Your boards both have vacancies. I think Board of Medicine has 7 and nursing might have 5. Has this hindered the ability of your boards to get work done? Have you had quorum challenges?
So I would like to take that first, if it's okay with you, ma'am. So the first answer is we are now down to 3. We just have 2 new members who just joined, and they'll be joining us. We actually have our board meeting tomorrow. So thank you to our partners and friends down at MODA. And no, I'm very proud to say that with Dr. Walsh's help and the other previous EDs, we've been able to always have quorum for all of our meetings. So special shout out and thank you to all of my fellow Board of Nursing Committee members, but we are committed to doing the work. So we have always had quorum.
Okay. Dr. Anderson.
Yes, I would add, thank you for the question. And I would say that, as Dr. Chaudhry did mention, across the country, boards are facing vacancies. I would think an additional challenge here in the district is the residency requirement that members of the board are required to reside within the district. And we noticed that many of our licensees do not reside within the district. Approximately 24% of the Board of Medicine licensees reside within the district. Others might reside in Maryland, Virginia, surrounding areas. And they work and are committed to DC, work in DC hospitals, work in DC offices, but are ineligible because of the residency requirement. And in addition, it's a good amount of work to be on a board. It's a volunteer position, labor of love for those who volunteer their time and are very, very hardworking. but we ensure that the board members review the cases thoroughly. They spend a lot of time requesting documents and trying to make fair decisions on each case. And so you can imagine that that can be a tough proposition for busy physicians and consumer members within the district. But we're always recruiting, and we understand that there are 4 new members coming through the pipeline.
Okay.
And we're definitely open to others who are interested.
Great.
And Chair Henderson, I also just want to share too with nursing, I gave the number of 29,000. There's literally under 3,000 registered nurses in DC that are district residents. And so when you look at
under 3,000?
Yes, ma'am. There's
Wow.
29,000 nurses that are licensed to practice in the district, but there's only 3,000 of us that are actual, district residents, as my colleague, Dr. Anderson, mentioned for the physician as well.
Okay. I think that does bring up an important distinction and a challenge in terms of, obviously we would always love to have DC residents, but the folks who also work here are very familiar with the district as well. And I feel like in many cases have a commitment. So we'll take a look at that.
There's also, I would also mention that for advisory committees and other subcommittees of the board, that residency requirement is not in place. So for any who are listening, who are interested in getting involved in some of the board priorities, those advisory committees are still an option, but for a board appointment, yes, that residency requirement does exist.
Right. In that regard, in terms of, you both provided numbers to break out the number of or the overall number of licensees that you have under each of the categories, et cetera. Does the board keep data on disaggregated by various other demographics, race, ethnicity, gender, et cetera?
Yes, the board does. For those who wish to share that demographic information on that workforce survey that I mentioned,
yep.
that can be collected, and the board does maintain that data.
And that's similar for the Board of Nursing. So every 2 years when our licenses are up for renewal, all that information is gathered as well.
Okay, so we will request some of that follow-up information from DC Health specifically. Dr. Anderson, you mentioned the subcommittees. We noticed that at the last board meeting, the Board of Medicine voted to implement an application subcommittee.
Yes.
What will this committee do?
Yes, so we voted to implement an application subcommittee to allow for increased efficiency in between board meetings to determine which applications need to go to the full board. So just a little background for you, Council Member Henderson, as well, Chairwoman Henderson, excuse me, as well as those who are listening. When an application arrives at the board and it is complete, so that means when all of the scores come in and background checks and et cetera, when there's a complete application, the staff can review that application. And if it's what is considered a clean application, quote unquote, like there's no questions, there's no encumbrances, the staff can go ahead. They have the delegated authority to approve that application. And close to 80% are considered clean applications, and they are approved within 30 days. Now, when there are delays, it's when there's some type of encumbrance. So there's a question about
background
check, malpractice, something, training issue, something. So then that needs to go to the full board. So this application subcommittee has been appointed on a rotating basis, subcommittee of the board, so that those applications can be reviewed. And if all 3 members of the subcommittee determine that whatever the encumbrance was that the staff had a question about, that doesn't need to go to the full board, we can then approve the staff to go ahead and approve that license in the interim. So that's a long way of explaining that it's to help advise and increase the efficiency of board application approvals.
And it's fairly similar as well, Chair Henderson, for the Board of Nursing. We have a delegated authority as well. So our staff members go ahead and do pretty much the same thing. We don't have a separate subcommittee for applications. That's pretty much delegated. And then our executive director, Dr. Terry Walsh, if there's anything that comes before that needs to be reviewed, those are pretty much immediately put on to the very next meeting. And I'm proud to say that if there are times that there's discipline issues, that we will go ahead, and more so for my fellow board members, we will go ahead and have a subcommittee meeting if necessary, so those things can be addressed in a timely manner.
That's great, because I think one of the things that people worry about is like, oh, if I missed if my application comes through in the period of time after a meeting, now I have to wait 4 weeks in order for the board to convene
No,
again.
that's definitely not the case here.
In general, like I said, most of the applications, the vast majority are considered clean applications, and they can be approved by staff.
Okay. I wanted to, hold on one second. My staff sent me a note. Okay. One of you mentioned that you were part of the interprofessional board chair collaboration group.
Both of us are.
Both of you. Okay, great. Wonderful.
I would like to share. So as the Board of Nursing, a few years ago, we had a conversation with Jacqueline Watson, who's here at DC Health, and Dr. Watson attended some of our meetings, and we were just having a very casual conversation, and she had the great idea that, and we definitely co-signed. So yes, we're in collaboration, not competition. But we did talk with Dr. Watson, and she came up with making sure that those key individuals on those boards that we mentioned, nursing, medicine, et cetera, that we get together, because there's a lot of cross-pollination, as you can tell, within the healthcare realm. And so since that time, we've worked, she shared information. We've had different meetings during when COVID happened. I mean, it's just been a very great opportunity for us to share any concerns that we have. So hence the name, it truly is just simply that. It's a forum for us to get together with our colleagues within the healthcare profession. So shout out and kudos to Dr. Watson for making sure that that gets done consistently. So it happens quarterly, and since the first meeting, we've been meeting consistently. So thank you again to her and Dr. Sharon Lewis for making that be a continual thing that we were able to participate in.
Are those meetings public, or is it just for you all to collaborate and chat?
So the meetings really have been internally for us as board chairs. We can definitely bring that back to Dr. Watson, maybe every other quarter or something. It could be held openly. But quite frankly, Chair Henderson, I think it's an opportunity for us to address the concerns just of the previous conversations you've been having about licensing and other things. It's an opportunity for us to kind of have our own little powwow, so to speak.
But I wasn't suggesting that they needed to be. I was just sort of wondering, as we're trying to, this was the first that I had heard that these types of meetings were happening. So I was just trying to get some more information. That's all.
But I will mention that there are plans for an annual symposium, which is a joint public meeting, a public symposium of the interprofessional board chairs addressing public health priorities from the district perspective. And that definitely would be open to the public now. Our efforts have been hampered by the pandemic, as you might well imagine, but we do plan to revive that this year, and we'll be choosing a theme that affects all the boards and planning a public forum. So stay tuned.
And I want to add, if I may as well, to add value, is that if you recall back in 2018, there was a committee of health, report on health and equity here in the district, and there were 9 priorities. And so a lot of the work is evidence-based. So it's not just a session where we, what are you all doing, but we're really looking at the health equity issues in the district and also health concerns and needs of the district residents based on that huge report back from 2018.
Okay. I'd love to come chat with you guys, just to sort of learn.
We'd love to have you.
We'd love to.
In terms of the various pieces there. Let me ask a question, Ms. Bardino, that's very specific to nursing. So you mentioned that the board also has oversight over the, I think you said 15 nursing institutions that we have in the district. Is there a report that you all do in terms of program quality? Like
There absolutely is. So there is an annual report that all of those institutions have to submit and report to our executive director. We also have an education subcommittee and a discipline subcommittee. And so what that report does, it's sent to all the leaders of those programs, not just, the Howard Universities or Catholic or Georgetowns, but all the other institutes that provide healthcare and then healthcare training and education. They then submit that report to our executive director. And so once that is then done, we review those reports annually, and that's also part of the metric that we use to continually to reapprove their licensing to serve here in the district.
All right. Do we need more programs?
You know, great question. I think that's an opportunity that I think it's a very loaded question that I'm not sure I have the time to answer. My gut response as Meedy Barnelli, sure, because there's always an opportunity, you know, to do that. But then, what are the barriers to coming into nursing? What are the barriers into any health profession? Quite frankly, as you just heard about the social workers, we saw the testimony earlier. So I think it's just an opportunity of, you know, maybe that's an opportunity, Chairwoman Henderson, to look at student loans. I still have about $15,000 that I'm paying to my school. And so that also becomes a barrier. There's an opportunity, I think, to make sure there's clinical pathways from some of our local schools that I know that the council member has already done. So the short answer, yes, would be great, but why are people not coming into healthcare anyway? That's kind of a much bigger question. But I think we have a sufficient number of programs here in the district. Can we have some more? Sure. But we want to make sure that they're not just pop-ups overnight. We want to make sure that they're providing quality care. And so I do know that DC Health, and again, with our board staff, does a great job of checking.
I was reading about the scandal out of Florida with the...
You should have a whole nother meeting about that.
And it just sort of underscored, I mean, I remember I had a long conversation with Dr. Lewis about like why we check what we check, why we do what we do in terms of the credential pieces. And then here comes this case that's sort of like served up on a platter of like, and here you go. You have
but Chair Henderson, that also speaks to why we do need to have in all healthcare professions, because the work that we do, not that yours isn't, everybody's work is important, but we truly are life and death as it relates to those in healthcare professionals. And so we have to make sure that there is some barometer of standard of practice. And so those individuals in Florida, unfortunately, were very negligent. We're glad they're found. And that is why sometimes there's a delay. If the public does not submit all those requirements, it's not an easy fix. As she said, 80% of the doctors get their done. But if you miss things, that criminal background check it's a necessity. So unfortunately, we don't have, you know, the Board of Health doesn't have, I mean, DC Health doesn't have purview over how long it takes to get a criminal background check. We just do the processing, but we have to make sure due process is done and that we do use just culture and all those issues.
Yeah, I would say that our primary goal is patient safety and safety for the residents of the district. It's not the protection of the doctor, it's protection of the resident. So we need to make sure that the people that we're licensing are competent, have been competently trained, because once we give a license, they can be a doctor in the district, they can do whatever, even if they say they're doing one thing and they decide to pivot and do something else, you know, that could happen because we've licensed them. So that's why we take it very seriously. And we do understand people get frustrated with unforeseen delays, but we take our job seriously.
Yeah. I'm trying to skip around here because I'm trying to keep myself to a time, but I don't see Councilmember Parker here, so I'm gonna keep going for just a little bit longer.
That's okay.
So Dr. Anderson, one of the things that has sort of come up, and I'm curious if this has come up in more conversations, is around what to do. Well, this is actually for both of you, what to do about midwives and doulas, and and whether or not midwives should be under the Board of Medicine, or should they have their own board, and whether or not doulas should be under the Board of Nursing, or if they should be in a sort of combined situation. Has there been any conversations around what is the best organizational practice here? I know I'm asking loaded questions here, but it's I feel like it's important for us to, you know, these are things that people are talking about. I'm just curious.
Right. So great question, complex question. This is why we've come up with a new committee on maternal professions to discuss that exact thing. Where is the best place to oversee, to license, to check qualifications, to handle complaints, you know, all the functions of the board. Currently, the certified professional midwives come under the Board of Medicine, or will come under the Board of Medicine, and doulas, while the nurse midwives come under the Board of Nursing because they're nurses. They have nursing degrees. So that's how we've chosen to go about it at this time. But you're absolutely right. I mean, there's a lot of crossover, and hence our board chair meetings to discuss those type of challenges. But I'll allow Meedy to opine.
Chair Henderson, I really don't have anything other to add than basically what she said. I think it's something that we're continually looking at. And I do know, again, 145 certified nurse midwives are licensed to practice here in the district. we do have our OBGYNs, obviously, that we partner with. So for me, I just think it's an opportunity to kind of, what does that scope of practice look like?
Yeah.
And nobody ever wants to have the conversation. It's all good when it's good, but what happens when it's not? And then we'll be for you with a whole other conversation. So I think it's just a matter of, what does that licensure look like? What does the regulations look like? And making sure that we're doing it in a very safe manner. But I think having that committee, and again, the IVCC that we talked about, is another great forum that we're able to figure that out. And obviously, as I'm sure you're aware, the mayor does the huge maternal infant conference every year that just started a few years ago. So continuing to have those conversations. But I think you answered the question for us when you said it's a very complex topic. So I don't think that Dr. Anderson or myself, can share wholeheartedly, but I do think that we do need to make sure that we figure out ways to make sure our district residents have access. Timely access, I think, is the issue for maternal and infant health.
Yes, and I would add that maternal health subcommittee is a collective committee. So it's not just doctors and nurses making those decisions, but there are key stakeholders, from members of the midwifery committee, OBs, public members, doulas, right? And so we want to hear everyone's voice to address this concern and make sure that we're protecting the residents of the district.
Okay. Nothing in the healthcare space I am finding is not meaty, right? There are so many different layers to it, right? And all the various pieces. In some conversations, I was having a conversation earlier with a school around like the recruitment of mental health professionals. And I sort of described it as sort of like whack-a-mole, right? Is it salary? Is it exam? Is it respect in the profession? Is it flexibility in scheduling? Like, what are the various tools? And there's no, I think, silver bullet, if you will. There are so many different other things, but just to be mindful of time, I have one other question I wanted to ask Ms.
Edie is fine.
Around certified nurse assistants. We heard some testimony earlier today. I don't know if you were on for that, around the desire to increase the number of CNAs that we have in the district. And my understanding is that while we have the license or certification, that we don't have any programs in the district.
So what I will share is that we have programs. Okay. What I will share, Dr. Henderson, I'm making you a physician now, Chair Henderson, duly noted. What I will share is that we have 4,460 certified nursing assistants in the district. What I will also share personally, and this was something I'm proud to say of as chair, prior to the COVID, I want to say that was early part of 2019, we actually had a forum here at DC Health where we actually asked all parties, the schools and hiring agencies, to come. At the time, Dr. Sharon Lewis was over DC Health in the Hurley department. And so she was there and we were able to have a collaborative conversation with the exact same question. What I think is important to share, and this is Meady Bardnelli sharing this, as chair, but also as a registered nurse, Chair Henderson, the money is not really that great. And so everybody's not necessarily wanting to be a CNA for $18 an hour or whatever it is. Let's just be very frank. And then the other issue is that you can't force people to go into that profession, no different than nursing, social work, dentistry, medicine, anything else. And so I do think that we've created a platform and a forum to always hear, and how the DC Health and the Board of Nursing can create collaborative conversations, but that's not necessarily within our board's purview. Our board's purview is to regulate and to make sure people are providing safe care, not necessarily create workforce pipelines, but we're here to support them. But we did do that where we had, and if I'm not mistaken, I don't have it in front of me, I can go back and get that information for you, but we had a very full room of both schools that were, that provide CNA training and employment opportunities. So I know DC DOES does a great job as well. And so recently, I'm sure you're aware, with the council member, Mayor Bowser, there is a Mayor's Health Task Force that was launched that's also looking at those things.
We're waiting on that final report that I'm told you can draft.
So I will just share that it's very important that people recognize and understand that you just alluded to it earlier. It's finance, it's how much people are getting paid to do these jobs, and getting $18 an hour to go into someone's home who has dementia, Chulia, who's incontinent, who, is not necessarily overly appealing. So what both myself and Dr. Anderson do is truly a work of, it's a profession. You have to be drawn to providing physical care for people. So I hope I answered your question.
No, you did. I think that that's something else that we have been talking specifically with the Department of Healthcare Finance around is, estimates show that we need more direct service providers, CNAs, et cetera. But we're not going to get people in that profession if that's minimum wage.
But part of that too, Chair Henderson, is because healthcare is now moving from an acute care setting. Healthcare is now more community-based, more home-based. So therefore, yes, people are still sick coming into the hospital, but I'm sure Dr. Anderson would agree, even half of the people in the ER really should be seen in urgent care centers. They really need to be able to go see Dr. Anderson in her office like tomorrow, not a month from now, and see their primary care physician. But kudos to you and to the board, because there is a CNA scholarship with that workforce scholarship that you all are offering. So hopefully with your help as well, that there's more advertisement for that, because that could also be a barrier. So if you have a low wage paying position and you still have to pay a $2,000, $3,000, $4,000 tuition for that 2 or 3 month training, that's a barrier. So I would just offer to continue to advertise that as well.
Right. As a family doctor, I would say that another thing I would thank the council for is funding of the loan repayment program and the health professional shortage programs that I know that I benefited from having worked.
I need to do my application.
Oh,
Sorry, Chair Henderson.
Conversation.
I'm gonna get that application to you today, Chair Henderson. Please approve it.
Well, I benefited from the National Health Service Corps scholarship, loan repayment, as well as DC loan repayment to help pay my medical loans. And that helped me to work in Northwest at Upper Cardozo Health Center for many, many years, serving an indigent population there. And so we want to just continue to attract others to come to areas of health professional shortage needs. And we encourage the council to continue funding such a program.
Yeah, I when I was a staffer at the council, we worked to revive that, because I knew that you're asking folks high staff areas, high needs areas, but you're not covering student loans. They most certainly would go into private practice to be able to cover that. Speaking of student loans, there was a big case in front of the Supreme Court today on that front, but we won't go into that. I have other questions that I think are more technical that I'll save for Herla for Thursday, but I want to say thank you to you both for being here. I really, really appreciate this conversation, and I look forward to working with you all more as we try to sort of address the health need challenges that we have across the district. So I appreciate your service, and thank you so much for being here.
Thank you.
Thank you, Chair Henderson. The Board of Nursing's meeting is the first Wednesday, so you're more than happy invited to come.
And Board of Medicine is the last Wednesday of each month. So mark off your Wednesdays. Come on.
I'm going to make my rounds. But thank you guys so much. And we're going to move on to pharmacy.
Thank you for having us. Have a great day.
Thank you.
Thanks, you too. Okay. So I don't think that they're going to okay, there we go. So that was great. What we're going to do next is hear from Dr. Tamara McCants, who is the board chair for the Board of Pharmacy, Dr. Anthony Jimenez, who's the board chair for the Board of Psychology, and wait, witness list is cut off here. And then Ms. Velva Spriggs, who's the board chair of the Board of Psychology. Velva Spriggs, who's the Board of Social Work chair. So I think they're resetting over at DC Health. No, actually, it will be 2 at a time. So Dr. McCants and Dr. Jimenez, logistically speaking. So. Okay, we promoted Dr. Jimenez. We need to promote Dr. McCants. There she is. Okay, good afternoon, Dr. McCants.
Good afternoon. Are you ready for me to get started?
Yes, ma'am, whenever you're ready.
All right, well, good afternoon, Chairwoman Henderson, members of the Committee on Health, and staff. My name is Tamara McCants, and I have the honor of serving as the chair of the District of Columbia Board of Pharmacy. On behalf of Mayor Muriel Bowser and DC Health Interim Director, Dr. Sharon Lewis, I am very pleased to be able to provide this testimony today on the Board of Pharmacy's activities and performance in fiscal years 2022 and 2023 to date. While I am originally from Brooklyn, New York, I am a very proud resident of Ward 7 for almost 20 years. I have had my entire pharmacy career in the District of Columbia and serving its residents, and DC is very near and dear to me. I am a licensed pharmacist and advocate for equitable care through an increase in the capacity of pharmacists to improve population health in underserved communities throughout the district. I have been serving on the Board of Pharmacy since 2006. I know I don't look like it. And as chair of the board since August 2019. As the chair of the Board of Pharmacy, I am responsible for leading board meetings and ensuring equitable treatments of members and the public in the licensing process. I am also a member of the Interprofessional Board Chair Collaboration, IBCC, in which my fellow chairs gave you details about in their testimony. My fellow board chairs of nursing and medicine already mentioned that together we collaborate and learn about public health priorities and the inner workings of DC Health and serve as ambassadors and advocates for advancing population health in the district. And the creation of this collaboration was so timely because it was right before we were hit with COVID-19 pandemic. And so this allowed for us to have a much more cohesive response. In addition to my responsibilities as board chair, I am a clinical assistant professor at Howard University College of Pharmacy, the only college of pharmacy in the District of Columbia. And I'm also the president-elect of the National Pharmaceutical Association, which is pretty much the pharmacy version of the National Medical Association, which represents the views and ideals of minority pharmacists in critical issues. Additionally, I currently practice at an independently owned community pharmacy located in the Bellevue neighborhood in Ward 8, with a focus on management of patients being treated for mental disorders. I'm also serving as a Code of Conduct Task Force member for the American Academy of Colleges of Pharmacy. And I also currently serve on the boards of community outreach groups, Community Education Group, where I serve as the president, Homes for Hope here in Washington, D.C., and the Beulah Rucker Museum and Educational Center. I received my Doctor of Pharmacy from Florida A&M University in Tallahassee, Florida in 2001, and I completed my residency with Grubbs Care Pharmacy in Howard University. I want to remind everyone of the mission of the Board of Pharmacy, and that is to protect and improve the public health through the efficient and effective regulation of the practice of pharmacy and pharmaceutical detailing through the licensures of pharmacists, pharmacy detailers, pharmacy interns, and pharmacy technicians. This requires the board to review the licenses of over 4,700 pharmaceutical professionals and several pharmacy technician trainee programs. The board regularly engages with practicing professionals in the districts and makes regulatory changes to improve the practicing environment. When residents, visitors, or those doing business in the District of Columbia complain of poor or improper pharmaceutical practices, the board may take disciplinary action. The board also ensures that pharmacy technician trainee programs offer high quality education through licensure in order to prepare the next generation of pharmacy professionals. The Board of Pharmacy issues 6 different types of pharmaceutical professional credentials. As of February 6, 2023, there were 2,265 pharmacists, of which 843 pharmacists have vaccination and immunization authority, 409 pharmacy interns, 1,172 pharmacy technicians, 183 pharmacy technician trainees, and 673 pharmaceutical detailers. The board has also approved 9 pharmacy technician trainee programs. In the district, licensed pharmacists dispense prescription medications to patients and provide counseling on the safe use of prescriptions and over-the-counter items. Pharmacists may also provide immunizations that are outlined in regulation, which includes hepatitis, shingles, human papillomavirus, or what we call HPV, tetanus, Tdap, meningococcal, influenza, pneumococcal, and other epidemic vaccinations as determined by the World Health Organization or the Center for Disease Control. Pharmacy professionals were instrumental. I like to say that we saved the world when we played a critical role in vaccinating people all over the world. But here in the District of Columbia, during the calendar year of 2022, pharmacists in the district provided over 250,000 COVID-19 vaccines. This ability to administer these vaccines was thanks to the flexibilities granted by the Public Health Emergency and the Public Readiness and Emergency Preparedness, or what we call the PrEP Act. The board strongly believes that the additional flexibilities granted to pharmacists and pharmacy technicians by the emergency declarations were beneficial to the public and is working on ensuring that pharmacists and pharmacy technicians retain these abilities once the public health emergency is over. Some of these flexibilities include more freedom to conduct COVID-19 tests and administer COVID-19 vaccines, as well as the ability to provide care via telehealth, so long as proper confidentiality procedures are in place. The Board of Pharmacy has participated in several initiatives over the past year to improve the practice of pharmacy in the district. This includes the recommendation of updates to the Health Occupations Revision Act, or what we call the HORA, which would expand the practice of pharmacy to be on par with many other states and jurisdictions. This was very important to us because it has been over 10 years since we looked at the Pharmacy Practice Act. These recommendations include administering medications, adding a pharmacy technician member to the Board of Pharmacy, allowing for independent administration of immunizations, and decreasing the age that pharmacists may immunize children from age 12 to 3, which is why the PrEP Act was very important to us because we were so restricted here in the District of Columbia. The board also recently updated the education and training requirements for licensure as a pharmacist or licensure as a pharmacist by applicants educated in foreign countries. This licensure application requirement now allows applicants who do not have a Social Security number to submit an affidavit without requiring proof of legal status in the United States. Additionally, applicants may now submit official transcripts in a manner other than postal mail. Welcome to the 21st century. The board continues to explore ways to improve working conditions for pharmacists. While we understand that we are here to serve and protect the residents of the District of Columbia, this can only be done when pharmacists are allowed to be in safe work environments. The board's Legislative and Regulatory Subcommittee conducted a workplace survey last year pertaining to the practice environment. For example, we looked at meal breaks and other breaks and the times of those breaks, posting notices while staff was out of the pharmacy and the content of the notices, and whether a pharmacist should be present in the pharmacy at all times, and the scope of work of pharmacy staff while the pharmacist is not present. I want to reiterate that these conversations are conversations that are happening nationally and not just in the District of Columbia. We looked at other jurisdictions' laws and regulations alongside the survey results, and will develop policy change recommendations on a pharmacy practice environment. Finally, the board is committed to finding ways to expedite the application review process. Earlier this month, the board voted to delegate the authority to issue new licenses and registration to the executive director and board staff which will decrease time for license approval. Previously, the executive director of the Board of Pharmacy was the only individual with this authority. I would like to take this time to thank my fellow board members of the Board of Pharmacy for their hard work over the past year. I would also like to express my sincere gratitude for the support we received from DC Health staff and look forward to our plans to expand the work of the board in this coming year. To the Committee on Health and to you, Chairman Henderson, thank you so much for your support of the board and the profession of pharmacy, including the additional funding that we received for licensing specialists. I appreciate your time and opportunity to testify before the Committee on Health and look forward to any questions that you may have for me at this time.
Thank you, Dr. McCants. Dr. Jimenez.
Well, good afternoon, Chairwoman Henderson and members of the Committee on Health. My name is Dr. Anthony Jimenez, and I have the honor of serving as Chair of the District of Columbia Board of Psychology. On behalf of Mayor Muriel Bowser and DC Health Interim Director, Dr. Sharon Lewis, I'm pleased to provide this testimony on the Board of Psychology's activities and overall performance in fiscal year 2022 and 2023 to date. I'm a licensed psychologist in the district, reside in the district, and have been on the Board of Psychology since 2014. I've been the chair of the Board of Psychology since approximately 2016. As chair of the Board of Psychology, I'm responsible for overseeing meetings, ensuring fair treatment of psychologists who may have dealings with the board, guarding the safety of the public, and improving population health by addressing health disparities in behavioral health. I'm also a member of the Interprofessional Board Chair Collaboration, a group of 7 DC Health Licensing Board chairs, my fellow board chairs in medicine, dentistry, nursing, pharmacy, social work, and professional counseling, and I meet with DC Health leadership on a quarterly basis to advance DC Health's 4th strategic priority, closing the chasm between clinical medicine and public health. Together, we collaborate and learn about public health priorities and the inner workings of DC Health and serve as ambassadors and advocates for advancing population health in the district. In addition to my responsibilities as board chair, I maintain a private practice in psychology, providing adult-oriented evaluation, treatment, and consultation in the district. Prior to establishing my independent psychology practice, I completed a 20-year career with the Federal Bureau of Prisons, holding various positions, including chief psychologist at the Bureau's flagship evaluation and treatment facility, then serving as regional psychology administrator for the Mid-Atlantic, and as a branch chief in the central office over sex offender evaluations. Additionally, I previously served on the board of directors for the District of Columbia Psychological Association and was president on 2 occasions. I hold a Doctor of Philosophy in Counseling Psychology from Florida State University. The Board of Psychology regulates the practice of psychology in the district, overseeing over 1,750 psychology professionals. Psychology professionals in the district include psychologists who are doctoral level professionals and psychology associates who are master's level professionals and who work under the supervision of a psychologist. In order to effectively support the psychology workforce and ensure the safe and competent delivery of psychological services, the board issues frequent policy statements and makes recommendations regarding education and training, scope of practice, and licensure requirements. The board may also conduct investigations when complaints are received and take disciplinary action when unethical practice is determined or a regulation has been violated. In the district, licensed psychologists evaluate and treat a broad range of human behavior and help patients and clients improve mental, behavioral, and emotional well-being through the use of evidence-based practices and methods. As of January 2023, the board oversaw 1,500 and 14 psychologists and 237 psychology associates. The board is committed to ensuring the safe and competent practice of psychology in the District of Columbia and has worked on several initiatives to accomplish this over the past year. The board has proposed recommendations to the Health Occupations Revision Act, HORA, which would expand the license types regulated by the Board of Psychology. If these recommendations are adopted, the new license types would include health services psychologist, general applied psychologist, and school psychologists, which the latter of which would involve a registration and narrower scope of practice. These three professional credentials would replace the current psychologist license. The board considered and adopted a new national examination standard for the psychology profession, which seeks to improve the qualifications and competency of individuals who are seeking licensure to practice psychology. In 2017, the Association of State and Provincial Psychology Boards, ASPPB, which oversees the national examination for licensure in psychology, updated the examination for professional psychology practice. The EPPP, otherwise known as. The revised EPPP examination now includes two parts, a knowledge-based test and a skills-based test. The revised EPPP2 is a more comprehensive and thorough examination of the knowledge and skill level of candidates for licensure. The board reviewed this new examination and agreed to be an early adopter of the revised EPPP2. This decision has proved to be prescient because the revised EPPP2 will be required in all jurisdictions in the US and Canada no later than January 1, 2026. The Board of Psychology for the district will be ahead of other jurisdictions in working out how the new examination will be administered. The board has drafted a policy statement on the EPPP2 requirements and determined that all applicants by examination or re-examination who submit their application on or after January 1, 2022 and are applying for psychology licensure in the District of Columbia are required to also take and pass both portions of the EPPP2. In addition, any individual who graduated on or after January 1, 2022 will also be required to take both examinations, but endorsement applicants who graduated before January 1, 2022 will be exempt from EPPP2. Finally, the board continues to facilitate the practice of psychology through telecommunications technologies, also known as telepsychology, including temporary and limited in-person psychology practice across state lines in order to provide the best quality and continuity of care. The Board of Psychology supported and promoted the participation by the district in PsyPact, an interstate compact created by ASPPB that facilitates the practice of psychology using telepsychology and temporary in-person face-to-face psychological practice for 30 days per calendar year per PsyPact state. As of February 27th, 2023, there are 8,287 persons who have the designation authority to practice interjurisdictional telepsychology, and 402 who have the designation temporary authorization to practice. This is a nationwide number of these individuals. Those are nationwide numbers of these individuals. 267 APIT providers and 10 TAP providers designate DC or the district as their home state location. The board also drafted guidance on telepsychology and remote supervision during COVID-19, during the COVID-19 public health emergency. This guidance was extended until January 31, 2023, and the board will decide whether to extend it further at the upcoming March meeting. The board is also working to fill vacant seats and requests that the council swiftly appoints and approves new members to the board as they come before the committee. This is especially important as the board wishes to proceed with the revision of the rules and regulations regarding the practice of psychology in the district. I wish to take this opportunity to thank the former members of the board, Dr. Eric Jones and Dr. Teresa Grant, and current board members, Dr. Joette James and Mr. L. Hamilton Ferguson, for their tireless work and valuable contributions to the work of this board during FY22 and 2023 to date. I look forward to working with the current board members and those whom we expect will be appointed soon. I would also like to express my appreciation for the support we receive from DC Health staff and look forward to our plans to expand the work of the board in the coming year. To the Committee on Health, thank you for your support of the board and the profession of psychology, including the additional funding for licensing specialists in fiscal year 2023. I appreciate your time and this opportunity to testify before the Committee on Health. I look forward to any questions you may have for me at this time.
Thank you, Dr. Jimenez, and thank you, Dr. McCants. We'll ask some questions here. So I'll first start with the vacancy question. Dr. Jimenez, I see that you all have 2 vacant positions for licensed psychologists, as well as one current member of the board, Dr. James, whose term has expired. Are you aware of what's being done to fill those positions?
I am. I've actually personally invested time and effort in recruiting psychologists. I think our board is well represented with, I think, what would be considered sound diversity across gender, and race, culture. I would hope that Dr. James would have her appointment renewed. She's not exhausted her terms.
Okay.
We have 2 other candidates in the pipeline, and I've actually personally gone to the mayor's office to advocate for their processing, and they've, as I understand it, taken a look at that and are working on it. So I'm hopeful that in the not too distant future, we'll have those 2 positions filled and we'll be able to resume this revision of the rules and regulations, which we had started previously.
Okay. Dr. McCants, I see 2 vacancies for the consumer members. And then, well, your term expires in a couple of weeks, as well as Mr. Friedman.
Yes, so we definitely, we've had consumer members cycle on and off the board, throughout the years, but we are definitely missing that consumer member voice at this time. And as was mentioned by my previous colleagues, the difficulty is that many of the licensees do not actually live in the District of Columbia.
Okay.
And so I think it's just difficult to find replacement board members. But all of the board members that sit on the board right now have been dedicated to the service. And so we will serve as long as we need to.
Okay. Do you know the percentage of the licensees for pharmacy who are actually district residents?
I do not know that number at this time, but I'm sure that's something that the staff can share.
Okay. Dr. Jimenez?
The question again, I'm sorry.
What percentage of your licensees under your board are actually DC residents?
Yeah, about 30%.
30?
Yeah.
Okay. I think that is an important piece to the conversation where we're talking about filling some of these positions, but also just in general, how various things are done. Dr. McCants, I asked a similar question that I asked the previous panel, the board oversees pharmacy tech training programs.
Yes.
Do you all do a, I guess, quality report that you put out in terms of, are they doing what they're supposed to be doing, or do we have some challenges?
Yeah, so I think at this time, we review the programs, and once the program meets the requirements, we focus our attention on the actual candidates that come through, because we have both the pharmacy technician trainee and the pharmacy technician license.
Yep.
So it is through those channels where we can determine the strength or the competency of pharmacy technicians that are licensed through the District of Columbia, because pharmacy technician training programs is a money-making business, not necessarily in the District of Columbia, but just all over, So the programs that we oversee in the District of Columbia, we can vouch for that they meet the criteria and that they are quality programs, but overall, it's not that all of our licensees go through those programs, if that makes sense.
Oh, I see. So just, let's say I took a pharmacy tech program in Florida. If I wanted to be licensed in the district, I just go through the process. I don't have to necessarily go through a district run program.
Exactly. So we confirmed that there was a training pretty much.
Okay. Well, how does that work in sort of the advent of lots of for-profit institutions who are popping up to essentially provide degrees, but not necessarily provide the training piece? What are the safeguards that we have in place?
So for the pharmacy technician piece, what we have to rely on is that we have the continuing education that is necessary for people to renew their licensure. Okay. And like most of the other professions, or I could say specifically for pharmacy, most of what you're doing on the job is specific for that type of practice. So we give you a license to be able to practice in that realm or as a pharmacy technician, but our oversight of the pharmacy technician is based on the renewal process. So, just like how people it's only become recent that we will even have oversight over the pharmacy technician. So that's a really huge step because they make a really large portion of the pharmacy work personnel.
Right.
And so the fact that we now have oversight of those pharmacy technicians allow us to have much more quality control of the type of professionals that are dealing with people's medications.
Right. All right. That's the thing that I keep thinking about is like, you're dealing with medications, which, it's not just counting, it's right. Dosage, don't combine, all of these different pieces that are largely important there. Sort of spinning off of that, to what extent does the board see its responsibility as, is it just strictly like the licensing piece and then also the oversight, right? Like, I think you all review complaints that come in and not necessarily the development of policy towards the broader issues that are coming from the profession?
Yes, no, you asked a lot. I just want to make sure I understand your question. We are not just a licensing body. We feel responsible for the practice in the District of Columbia.
Right.
And so we have board members that are active on a national forefront, several board members that participate in item writing, that participate in the national and regional boards of pharmacy meetings. So we are constantly learning what is the national landscape, what's best practices in other places, and seeing what we can implement in the District of Columbia. So we make sure that we keep communication open. We have a newsletter that we send out to all of our licensees. We encourage people to come to the Board of Pharmacy meeting. It's also one of the reasons why we're advocating for a pharmacy technician seat on the Board of Pharmacy, so that we can make sure that we hear from their perspective and hear their voices, as we largely realize more and more the impact of having a well-trained, competent pharmacy technician in the pharmacy space, so that the pharmacist can do more with counseling and managing people's medication. So we look at the profession as a whole and how we can best shape the profession in the District of Columbia. And that's why we're moving forward with trying to advance the Practice Act.
Does that include recruitment and retention of workforce?
Well, I can say as much as we can, because indirectly it is, because what we have done, especially recently, is really trying to get involved in terms of what is the work environment, really trying to get, and that's why we administered the survey, because, you know, we hear things, we work in different practices, but we wanted to get a comprehensive view. What is the work environment, and what are the woes of the work environment, so that we can see what can be addressed legislatively and what can be addressed almost as a culture, if that makes sense. Because as members of the Board of Pharmacy, we're also leaders in the pharmacy community. You know, we impact what people think about pharmacy. I'm in academia, I impact what the next generation of pharmacists think about pharmacy.
Right.
So all of that, in essence, indirectly affects workforce development or recruitment and retention.
Okay. And Dr. Jimenez, in your testimony, you know, you already spoke to the work that you all are trying to do to sort of change the requirements and get up to speed. I thought it was interesting that you all adopted a new examination standard, especially given earlier testimony about an exam for a different board. What was the impetus for the decision to change? And also, I guess, unlike some of the other boards, you had the availability of a new test to try, like there was another option. I don't think that, like, I think in pharmacy, there's like one test, right? Mm-hmm. All right. So I don't think you had the option of like multiple tests. So I'm curious, Dr. Jimenez, if you could talk a little more about that.
Well, those are good questions. Well, in psychology, there really is only one test. It's the national examination. It's called the EPPP.
Okay.
So that's the one test, and it's been in place. That's the one that I took, and everyone before me and up to now took. ASPPB, that Association for State and Provincial Psychology Boards, that oversees the development and administration of that national exam, was approached by jurisdictions in the United States. So they didn't decide to do this arbitrarily. They were approached by states and jurisdictions with a concern that psychology as a profession was the only profession that didn't have a skills-based, the only mental health service profession that didn't have a skills-based test. And so based on the request by a majority of the jurisdictions, ASPPB embarked on this project to revise the test. And so the revision has two parts now. Instead of just the knowledge-based part, it has a knowledge and a practice, a skills-based exam. I did sit in earlier and listen to the concerns about the social work exam, and it generated some thoughts, because there does appear, even in that exam, for there to be some discrepancy on pass rates based on race. The thing about the EPPP2 skills-based test is that the designers of that were a diverse group. That's to say, persons across all races, gender, ethnic groups. And every item was cross-checked, and numerous items were changed because of concerns about primarily racial bias.
Interesting.
Now, that exam is going to be implemented by everyone. It's not going to be optional by January.
Oh, I see. So we're just the first ones to adopt it, but it's going to be a rollout nationwide.
That's right. There are about four or five states or jurisdictions right now that have agreed to do it. Some things will have to be ironed out. So I'm glad that we are at the forefront of that. We won't be catching up, and we'll hopefully have this in place. Now, we don't know what those pass-fail rates will be in the future. We'll have to see.
Right. Okay. Another question for you in terms of, I guess, information, right? I feel like information in these spaces can help to illuminate. Do you all, Dr. Jimenez, do a survey of your active licensees in terms of asking what, in what field you're practicing? And by that, I mean, or excuse me, what setting you're practicing. So how many of you are practicing in schools? How many of you are practicing at hospitals? How many of you are doing private practice? Do you have any ideas on that? Because one of the things that, we get the overall census number. And what I like to say to people was like, well, in DC, if we just looked at, say, like the American or the DC bar, numbers, the number of quote unquote practicing lawyers in the district will look very different than people who actually practice law from day to day. So I'm curious if that's the same case on psychology.
Yeah, I don't have all of those numbers, but I think we can generate those.
Okay.
I know that one of the things that we've done to try to address these workforce issues is to establish a special relationship with stakeholders. The District of Columbia Psychological Association would be an example. So they serve primarily as the guild. That's their role, right? They're kind of that's what associations often do. So practitioners bring to them concerns. I happen to be on their listserv, and so I can see the chatter that goes on. And so we are actively pursuing a relationship with them to identify concerns and to address them. In the district, you have psychologists who work at St. Elizabeth's, for the courts, some of the hospitals.
And I just feel like this type of information is helpful in terms of us having a true understanding of the landscape, but also when, I have parents who ask in another hearing, like, well, we're providing money for X, Y, or Z, why don't we have any more school psychologists? And I'm like, okay, I can't like drop people out of the sky. But also I know that our schools are also competing with hospitals, who are competing with the nursing homes, who are competing with like all different types of things in terms of the work and the practice.
Yeah. Well, the school psychologist issue, I mean, I won't take up much more of your time, but unless you want me to, but that's been a controversial issue for a while. If you've not been made aware of it, you will be, I suspect. But
I've learned a little bit about that. Dr. McCants, I want to ask a little something different as it pertains to the opioid crisis that we're seeing in the district right now, and I guess I would say like DC's situation is a little bit different than perhaps what, got the focus of the news, right? It's less prescription pills and those kinds of things, but other uses of drugs. And, to what extent does this come up in conversations in terms of the Board of Pharmacy around the work and scope of practice, but also how you all look at complaints, necessary discipline?
I almost felt like you might have been a fly on the wall for my last 8 Board of Pharmacy meetings, because during the Board of Pharmacy meetings, I love pharmacy. I am a very strong advocate for pharmacists and pharmacy practice. And I know that pharmacists are a major solution to all public health crises. We demonstrated it already with COVID. But we already knew that. We just showed everybody else what we already knew. So And the District of Columbia is number 2, second to West Virginia when it comes to the opioid crisis. So it's a really huge deal for us. But like you said, it's different. It's fentanyl, it's heroin, it's different. And so what I implore the pharmacists to do is to just think about how we can address the crisis, make sure that we have naloxone and staff get comfortable with talking to people about substance abuse, because we are community pharmacists are the most accessible healthcare professional. We see people more often than any other healthcare professional anywhere because we're on every corner. But the barrier is always and has always been in the District of Columbia is lack of compensation for pharmacy services. We straggle behind in the country, especially with us having such a large Medicaid population. While DC has the #1 insure rate, meaning that most of the people are insured more than any other place in the country, we still have some of the largest health disparities, #1 and 2 in, with HIV and AIDS and chronic diseases, and like as mentioned, opioid. And I really know it's because the pharmacists are underutilized. When you look at other states and other jurisdictions and where pharmacists are being compensated for services, we straggle behind the country. We're always like number 47, number 48. We were one of the last to allow for pharmacists to be immunized. We were one of the last to for Medicaid to compensate pharmacists for immunization. So that was a big population that we couldn't even do anything with because we were not compensated. And I think it's long overdue for us to just talk about the compensation model for pharmacists so that we can really be prepared to address some of these health issues that's ongoing in DC.
Thank you. That's heartening to hear. I have my staff and I, some of the other agencies know this, like if you have a board, we read board minutes because we feel like that is the best way for us to try to find out what's been going on, what y'all talking about. So whoever your secretaries are, if they could take a little bit more detailed notes, that would help us a little bit.
Our secretary is amazing.
But I appreciate you hearing that because, or I appreciate hearing that from you because this is definitely one of these things that we have got to get our head around in the district. And I do want to say kudos to the pharmacists. I remember sitting in a CVS and, they're fulfilling prescriptions, folks coming in for flu shots, folks coming in for COVID vaccine shots. And it is literally like air traffic control. Okay, if you hold on 1 second, and then the phone's ringing, and then somebody's coming through the drive-thru. Like it's just so many different pieces. And I do feel like pharmacists really showed up for community in the work. And perhaps that hasn't been elevated enough in terms of that. Dr. Jimenez, I want to ask one last question, and we've been joined again by Councilmember Parker, and see if he has any questions here. As part of the survey, Dr. Jimenez, of things that you guys figure out about psychologists or licensed practicing folks, how can we incentivize more in that profession to accept Medicaid? Is it a reimbursement issue? Is it a paperwork issue? What is it?
Yeah, I think it's both.
Okay.
I mean, to be honest, yeah. So,
I mean, I guess I can ask this for either one of you. Does Department of Healthcare Finance ever come talk to your board?
No. We have not had anybody from Department of Healthcare Finance to attend the Board of Pharmacy meeting that I can remember.
I mean, you've been on the board since 2006.
Let me not say that. I would say within the last year. Charlene Fairfax used to definitely come to the Board of Pharmacy meetings, but she is a pharmacist, so it's almost like, okay, she's coming to let us know that she's there, and she's always been very supportive. But I would like to see more from the Department of Healthcare Finance to just come and talk to us so we can figure out how to partner so we can address these disparities, because they are very, very real. And, maybe the Board of Pharmacy meeting is not the best place to actually do that. But some conversations need to occur so we could figure out some solutions.
Yeah. Dr. Jimenez?
Yeah, I would just support with what Ms. McCants has just said. Most psychologists in private practice don't deal with persons who are receiving Medicaid. Many of them don't even want to take Medicare. So I have a patient who's on Medicare and Medicaid, and so Medicare pays me, just to give you a concrete example,
yeah,
for a 45-minute session, around close to somewhere around $100, right? And then that's forwarded to Medicaid, to some office in the district that's supposed to make up for the difference that Medicare doesn't reimburse. And they send me a check for $1 and change. That's what they send me. $1.
Wait, I thought they were supposed to make up the difference.
Yeah. Well, again, I've contacted the program, and I was told personally that all they do is they respect what Medicare pays, and they don't pay the difference, as is true for other people, right? So I'm a retired federal employee, and so I'm actually on Medicare. And I have a supplement, and the supplement picks up what Medicare doesn't. That's how it works. But that's not true, at least not with I've had like 2 patients or so, and that wasn't the case with them.
Yeah.
So I don't see Medicaid patients. I take Medicare for ethical reasons. But most psychologists in private practice don't take any Medicaid. It's just not, to them, it's not financially reasonable.
Okay. And I wasn't meant to put you on the spot.
No, that's fine.
Chair the board, I think it's certainly important, and I appreciate you sharing your perspective here. And one of the things I really trying for the Committee on Health is for us to get to a healthcare system ecosystem. And so I think it's super important then that the Department of Healthcare and Finance, which has so many residents who are getting their insurance through them, is having conversations with providers around what it would take, what are the challenges, how can we improve streamlines, all of these different pieces, especially when we're talking about we're bringing on a new MCO, we're doing all of these different things. But, I think we get a lot of complaints from folks who say, I can't find a doctor, or if I find a provider, it takes X long, or challenges with prior authorization, or challenges with so we got to figure out some things here.
Right.
I am over my time.
Yeah.
Councilmember Parker, I know you weren't here for their testimonies, but I don't know if you have any specific questions for Dr. McCants, who's the chair of the Board of Pharmacy, or Dr. Jimenez, who's the Board of Psychology.
Very quickly, Dr. Jimenez, it is my understanding that you all have transitioned your licensing requirements. And you talked about that as I was scanning your testimony. And you're kind of now leading other jurisdictions. Can you speak to what lessons learned you've found as a board in this new assessment requirement shift that you've taken on as the rest of the country looks to catch up by 2026?
Yeah, well, we've just implemented this. And so I think literally we can count on one hand the number of people who've had to take the new revised licensing examination. So we don't have a lot to go by. I know that there has been some chatter on the District of Columbia Psychological Association listserv about this second examination. And so there are people who are anxious about that and think that the district or that the board doesn't have to implement the second half the test. As I said, that's not going to be an option. And so there's only be one test, 2 parts. The question now, which is what the board is dealing with, is when to administer both of those parts, whether to do them at the same time or whether to, say, do the knowledge part, allow the knowledge part when they finish their coursework, which is when they're probably best prepared to pass the knowledge part, and then to take the skills part after they've had internship and gained some more additional practical experience. That's a thought that we're grappling with, and if we go in that direction, then how would we go about doing that? We're in the process of trying to figure that out.
No, that is really helpful. No, that is, yes. One other quick follow-up. In your testimony, you spoke to like telehealth and
yes.
To the greater capacity that the board, but also psychologists across the district have for doing telehealth. That has pros and cons. The pro is obviously for worker conditions for psychologists and the ease of providing care. The drawback is that it's harder for in-place providers to get people to commit to working on the ground, or at least that's some of the feedback that we're hearing when you're trying to attract a psychologist to work in an office 5 days a week when they can just do it through telehealth. Is there any feedback to that in that you're hearing from partners and or clients around just the pros and cons around the telehealth?
Yeah. I mean, that's an excellent question. So again, I don't mind sharing my personal experience. So I see patients individually in person, and I also do telehealth. To me, the pros outweigh the cons. I'm going to make more money this year because I get a lot of calls from people who say, I can't find somebody who wants to see me in person, right? So I'm sort of validating what you've been hearing. That's anecdotally my experience. On the other hand, I have people who are retired, some who live on the other side of the river where there's very little access, and they can only do telehealth. And so to them, it's a godsend.
Yeah, and I believe it is a godsend, and I do think we need to. And Ms. McCants, I'm coming to you next. And I think we're in a new normal, and in many ways we have to adapt. I do know that one of the drawbacks, though, is that providers, CBOs in particular, that are doing work on the ground in person are having a hard time. To that end, how are you all as a board tracking feedback and or the impact of this move towards telehealth on psychologists across the district, if you're doing that at all?
We're not doing that at all, but we can. I'm making a note of that. And
yeah, I think that would be helpful. I feel as though there's a disjointed feeling. I feel as though it's disjointed. At the federal level, everybody is virtual. At the local level, we have the mayor calling for people to come back. We have needed services that are being provided on the ground in buildings in person, namely within our schools, our recs, and the like. At the same time, to your testimony and to what we know, there are a lot of people wanting to do more things virtually. So things just feel very disjointed right now. And so I think as much data and information that we could collect would be great.
Council member, if there's anything that your office would like us to consider, I've already made some notes.
Okay.
Please forward it to the board and we'll be happy to work with you.
Yeah, I will follow up with you. And I would just echo what Chair Henderson said to all those that are listening about meeting notes. I'm a fairly new council member, but I am trying to beef up on just the work that you all are doing in your meetings and appreciate it. Ms. McCants, I'm going to come to you. You talked a bit about worker conditions. And improving the worker conditions. And I missed your verbal testimony as I was jumping from another hearing, but I did read and scan your written testimony. You talked about a subcommittee that is investigating worker conditions as well as comparing them to other jurisdictions.
Mm-hmm.
What are some of the findings?
Mm-hmm. So what we were doing, so we have a subcommittee on a legislative subcommittee where we look at our current laws and regulations, look at what's happening in other jurisdictions and figure out how we can update ours in the District of Columbia so we can enhance pharmacy practice and therefore be of best benefit to the residents of the District of Columbia. So what our initial work was to first just administer the survey and just collect data about what the work conditions were in the District of Columbia and see how that looks in comparison to, national work condition surveys, et cetera. So we just recently submitted the survey and gathered all the data. We have not compiled and, reported the results of the survey yet. But what I can say across the country, and even like just in terms of when we bring pharmacists in sometimes for infarctions, we hear a lot about the work conditions. And so we're just trying to figure out what can we do, if anything, legislatively to try to enhance the work conditions so that we can decrease medication errors and decrease, just bad, poor work conditions so that the pharmacists and pharmacy technicians can do the best work.
No, that makes a lot of sense. And so it seems like that work is very much ongoing. And a question I would ask of you and the same of you, Mr. Jimenez, like what support would you need from this committee as you're engaging in that work?
So,
Dr. McCann,
I first of all, I am just so very excited by the freshness of the members of this committee and the balance of seasoned and new council members serving in this space on the health committee. And we are looking for partners for the pharmacy community to be able to hear what the pharmacists are able to do, hear what the pharmacists need to ultimately, again, meet the health disparity needs in the District of Columbia. So specifically, we want you to hear us, if that makes sense. So when we tell you as a pharmacy community, as a board of pharmacy, that these are the conditions and these are the things that we need to, I don't want to say regulate because everything is not punitive, right? But we want to have as strong of a voice as corporations. And I'm just going to leave it at that's what we need.
I thought that was a very tactful way of putting it.
Thank you.
Mr. Jimenez, I would ask you this question. What support?
Yeah, I think as the Board of Psychology sort of endeavors to go back and resume changing the rules and the regulations, as we look at telehealth, as we look at the licensing, the licensing revision that will establish 3 licenses instead of 1, that there be a line of communication with the council.
Can I ask a quick question there? 3 licenses instead of 1, and it's my understanding that those licenses would allow more entry-level positions within the field of psychology based on your testimony. Can you just speak more to that? And I'm sure you did during your testimony, but I missed it. Why is that necessary? And I asked that because we heard a number of people testify earlier, namely directed towards social work. But if you could just speak to why you believe that adjustment is necessary, that would be helpful.
Well, the healthcare psychologist is probably a license that represents what most psychologists do today. So that's just a change of name. That license will apply to people who work in any healthcare setting, essentially. The applied psychology license tries to address a vacuum. There are psychologists who work for organizations, and they do organizational development. I know some who work for the World Bank, They have an EAP program, for example. And so they're in a position to actually evaluate and treat individuals. Those psychologists with organizational psychology degrees may do team building. They may give advice to people on how to handle problem employees. They may address issues that actually involve actions that can have physical consequences or psychological consequences to the recipients of those services. And so the idea is not to require everyone to get an applied psychologist who isn't working in a health setting, but only those whose work involves interventions that can have consequences. So that's the second one.
And again, are there data points from other jurisdictions that you can look at to kind of map what impact that might have on both who's taking the assessment, but also who's attracted to the field?
Yeah, there are some jurisdictions, I can't tell you exactly how many, who have an applied license. They don't make up a majority. The Association for State and Provincial Psychology Boards, at its biannual meetings, has gotten feedback about issues, complaints, concerns that people in these other settings have, where there isn't really any accountability. Now, yeah, and then the third license, which would be a registration. That's the one that we've gotten the most blowback from so far, but we've worked with the school psychologists for the last 4 years or so, 3 or 4 years. We established a committee to actually look at revising the rules and regulations and considering the incorporation of school psychologists under the Department of Health. It's the only remaining health profession that isn't under the Department of Health. And the argument there was that they're not a healthcare provider, but they are. They evaluate kids, they diagnose them, and they prescribe programs. And so by any standard, they are a healthcare profession. And that's the reason the board wants to incorporate them. In addition, doing that then allows the board to implement a standard not only that applies to public schools, but private schools and charter schools. The charter schools absolutely have no regulation. And so the idea is to provide equitable care across all of the settings where there are school psychologists.
Yep.
And to have one central place where people can, if they need to file a complaint or express a concern, can go to get a fair hearing, if you will, and to have their complaints addressed. School psychologists tend to have master's degree more often than PhDs or doctoral degrees. So there have been issues concerning what they're called, whether they can be called school psychologists because the profession of psychology has a doctoral degree as its professional standard. But we've worked with school psychologists in trying to, and we'll continue to work with them. We've invited them to meetings, and we haven't done anything lately because of the pandemic. But as we move forward with this, we'll contact them again and try to get them to work with us. We might have one of them on the board, right?
That would be a good idea.
That's right, to have equal representation. So, and I think we're trying to be flexible and to work with not restricting who can be a psychologist, but on the other hand, you want to have reasonable standards.
Yes. No, that resonates. And I believe Ms. Spriggs still needs to go, right? I missed that. Yes. So Ms. Spriggs needs to go. I'm going to ask one more question. I know time is up, but the question around greater coordination between healthcare finance, if you all could both just parse that out very briefly. So Ms. McCants, I'm going to ask you again to just revisit that and more clearly articulate for me, like what support you need there.
Okay, so I think that one thing that we all as healthcare professionals have to realize is the monetary side to it and the compensation and the business of healthcare. And when the business of healthcare is not equitable, then the people that can afford the healthcare can get the best healthcare. In the District of Columbia, we know that we have the lowest uninsured rate. So we have many people, everybody have the highest number of insured people as a jurisdiction. But when a lot of those people have DC Medicaid or Alliance, that automatically eliminates the services that pharmacists can provide for them, because we have private payers and then we also have Medicare that compensate for certain services, but our local state health insurance does not compensate for services that those other insurance companies do. And that's not, and that's overall clinical services. And that's also the same for when we start talking about reimbursement for products. There a lot of times when you dispense a prescription in a pharmacy, you're losing money on a prescription, especially when you're utilizing MCO, because it's not the same as what a federal plan or another private plan will pay. So we just want to have those type of conversations so that we can have equity for everybody, whether you have a private insurance or Medicaid or Alliance.
No, that makes sense. That is my time. But
I wouldn't add anything. Dr. McCants, I think, just did a fine job. I would just repeat the same thing that she said.
Okay. Well, thank you all.
We thank you for the opportunity and we look forward to building a stronger relationship.
Absolutely. And I believe Councilmember Henderson may have had to step away. I'm going to quickly check. And I'm going to take that as a yes. But yes, the motherhood calls at all times. But we do appreciate your sharing, and we will certainly follow up with you. And so thank you.
Thank you.
Thank you.
And next, I believe we're going to hear from the Board of Social Work, Ms. Velva Spriggs. I see you on here. Are you here? There you go. You can begin your testimony.
Well, thank you very much. It's been quite a long day, hasn't it?
It has been a long day, but this is important work.
Yes, it is. I want to say good afternoon to the council members here. Council Member Parker. I'm not certain whether Chairwoman Henderson is present, but of course I would want to greet her as well, and other members of the Committee on Health and staff. My name is Velva Taylor Spriggs, and I have the honor of serving as chair of the District of Columbia Board of Social Work. On behalf of Mayor Muriel Bowser and DC Health Interim Director, Dr. Sharon Lewis, I am very pleased to provide this testimony on the Board of Social Work's activities and overall performance in fiscal year 2022 and 2023 to date. I am a licensed independent social worker, and I have been serving on the Board of Social Work since 2012 and as chair of the board since 2017. As chair of the Board of Social Work, I am responsible for orchestrating meetings and ensuring equitable treatment of members and the public, as well as addressing health disparities in mental and behavioral health. I am also a member of the Interprofessional Board chair collaboration, the IBCC, which was mentioned earlier by some of my fellow board chairs, this is a group of 7 DC Health Licensing Board chairs. My fellow board chairs in medicine, dentistry, nursing, pharmacy, psychology, and professional counseling, and I meet with DC Health leadership on a quarterly basis to advance DC Health's 4th strategic priority, closing the chasm between clinical medicine and public health. Together, we collaborate and learn about public health priorities and the inner workings of DC Health and serve as ambassadors and advocates for advancing population health in the district. Now, in addition to my responsibilities as board chair, I am a part-time family engagement liaison at DC Child Care Connections of Kids Comprehensive Services and past lecturer at Bowie State University's School of Professional Studies, Department of Social Work. Over my 50-plus year career, I have worked in many university and private positions, sector positions, and in various capacities at all levels of government service in areas related primarily to children's mental health. I am also a former Peace Corps volunteer. I hold a Master of Social Work degree from the University of Pennsylvania and an honorary doctorate from Morgan State University for my work in civil rights. The practice of social work is the rendering of professional services to individuals, families, and groups that involve the diagnosis and treatment of psychosocial problems according to social work theory and methods. Depending upon the level at which an individual social worker is licensed, the professional services may include psychosocial evaluations and assessments, counseling, psychotherapy, referrals, advocacy, mediation, consultation, research, administration, education, and community organization. The mission of the Board of Social Work is to provide oversight to licensed professionals and ensure the health and safety of citizens and visitors in the District of Columbia through the provision of healthcare services. Now, to accomplish this mission, the board oversees over 6,000 social work professionals and ensures that these individuals are providing safe and competent social work services to residents, visitors, and those doing business in the district. When complaints of improper or unsafe practice are received, the board is responsible for conducting investigations and taking the appropriate disciplinary actions. Additionally, the board regularly makes recommendations on policy and regulation changes to improve the practice of social work. We require that licensed social workers renew their licenses biannually upon completing 40 hours of continuing education credits that include LGBTQ+ and our public health priorities. The Board of Social Work issues 4 different types of social work professional licenses. As of February 8th, 2023, there are 4,439 licensed independent clinical social workers, or LICSWs, and 43 licensed independent social workers, LISWs, both of whom require a master's degree and may practice independently. There are also 1,550 licensed graduate social workers, LGSWs, who have a master's degree, and 59 licensed social work associates, LSWA, who have a bachelor's degree, both of whom require supervision. In addition, social work students and interns are authorized to practice without a license, provided that they practice solely under the appropriate supervision of an LICSW or LISW in the District of Columbia. The Board of Social Work has continued to work over the past year to improve the practice of social work and expand the social work workforce in the district. The board has been conducting outreach to local universities to encourage graduates to join the social work workforce. This past December, board staff presented on licensure to the graduating class at Catholic University as an example of this endeavor. And I personally also presented on social work licensing requirements at Bowie State University within the last 2 or 3 months. The board is also having discussions on easier pathways for licensure, such as regional reciprocity and compacts, and plans to continue these discussions in 2023 and beyond. Additionally, the board issued a policy statement last November, temporarily extending guidance on remote supervision during the COVID-19 public health emergency. Social workers licensed in the district may now engage in telehealth practice, including providing supervision via communication technology, provided that licensees comply with the applicable standards, the standards that standards that do not involve, standards that do not involve synchronous real-time communication, such as email or text messaging, which, while permissible as part of telepractice and telesupervision, does not constitute immediate supervision. This policy was extended until December 31st, 2023. The board is also preparing to issue supervised practice letters. These letters would allow graduates who are waiting to take the Association of Social Work national exam or are waiting for test results to begin practicing social work under supervision. This allows potential social workers to practice sooner, bolstering the social work workforce and improving access to social workers. Finally, the board has created a space for dialogue between the social work community and ASWB, which is the Association of Social Work Boards, to discuss issues with the exam, including but not limited to recent research findings on racial disparities in pass rates. It is important to note that the board is not responsible for designing the exam, and licensing standards are crucial to determining whether an applicant for licensure is competent. The board is concerned that reported racial disparities in pass rates is a serious problem. We acknowledge this. We are concerned about this. This is not new information. This has been around this concern has been around for some time. And I suspect that the same issue is faced in the other professions where there are disparities in pass rates. So it seems that universally, this becomes something in our time that we have to pay very close attention to. And for that reason, we are working very closely with our local universities. We work with NASW, with ASWB, to support a restructuring of the exam. We know that there are some who would advocate for the elimination of the exam. We are not advocating the elimination of the exam. We are looking to restructure it in order to address problems of disparity and whatever other issues that may generate problems involving competency, because we must maintain a standard of care. The board looks forward to receiving a presentation on the new exam from the president of ASWB at our next Board of Social Work meeting. We have had discussions in our national meetings and with the ASWB locally about our concerns. And for that reason, the president herself is coming to speak to us, and we're inviting the public to come. The council members are also invited if you would like to attend. Our meeting is held once a month on the last Monday of the month, and it begins promptly at 10 a.m. Please come if this is an area that concerns you. I would like to take this time to thank my fellow members of the Board of Social Work for their hard work over the past years, many years. I would also like to express appreciation for the support we receive from DC Health staff and look forward to our plans to expand the work of the board in the coming year. We do have a vacancy, and we've had a vacancy for some time. We have worked with the Mayor's Office of Talents and Appointments to fill that vacancy. It is the vacancy for the licensed social work associate. We do advertise the vacancy on our website. We announce the vacancy at our board meetings, at our open sessions with the public. So we are continuing to be concerned about filling that vacancy. To the Committee on Health, thank you for your support of the board and the profession of social work, including, which is one of the best professions, by the way, the Board of Social Work, including the additional funding for licensing specialists in fiscal year 2023. I appreciate your time and this opportunity to testify before the Committee on Health. I look forward to any questions you may have for me at this time.
Thank you, Ms. Briggs. And I really appreciate the work that you do and your testimony. I'm going to jump right in. You probably heard the testimony as we did with many that were decrying the racial disparities in who's passing the licensing exam, and you spoke to that. You said that it is a concern for the board. What is the board doing in response to the clear racial disparities and who is passing the exam?
Very big question. And I would say that we are doing a number of things in relationship to our membership in ASWB. When we attend their meetings, we are among the first to raise questions about this issue because we are concerned about the same issue. We see it as rather complex, however. We're living in a time when this kind of issue really comes to the surface in many respects and across many professions. We do feel that it is important and that we must address it. It is significant, it is apparent, and so there is no lacking of acknowledgement about the fact that this exists. So we have in fact suggested to ASWB that they have a series of meetings throughout the country with individuals who have sought to get their license, but have failed to get it because they've not passed the exam. And so ASWB has taken us up on that recommendation. And they held one of their first meetings here in the District of Columbia about 3 weeks ago, or maybe a month ago, where they invited the public to come in and talk to them about their experience with the exam.
Any takeaways from that conversation that you know of? Not to put you on the spot, but
curious. It's okay to put me on the spot since I wasn't there. I wasn't at that particular meeting.
Okay, well, no, if you're not, if you weren't at
yes,
that
but what
meeting,
I do plan to do, yes, what I do plan to do is to inquire of ASWB what the results were of that particular meeting. I know that they're holding a series of these throughout the country, which we feel will be invaluable as they do their research to understand why these disparities continue to exist. There is a pattern, and we want to understand it. In addition, we certainly are open to hearing from our own stakeholders here in the District of Columbia. They come to our board meetings, to our open sessions. They tell us what their concerns are with regard to the exam. Some have even recommended that we eliminate the exam. We have said to them that as a regulatory board, we certainly have to operate within the confines of our mission. However, we are very interested in being instrumental to helping to address this problem with ASWB, because we too are a member of ASWB. And so those are a couple of things that we are doing. There's one other thing.
I think you made it very clear that you're not supportive of doing away with the assessment.
Did I make that clear?
You made that very clear.
Good.
Thank you. Very clear. I do want to follow up. So we know that there is a shortage. Well, there's a shortage of social workers in the places where we need them, namely in our schools, in partnership with many CBOs. At the same time, I believe the data, and you referenced it, for nearly 4,500 clinical social workers are on your rolls. And I believe the numbers of licensed social workers have increased over time. Mm-hmm. And part of that gap, or that tension where we're seeing more people become social workers, but fewer social workers in places where they're needed, i.e. schools or in partnership with CBOs, is because of the presence of telehealth opportunities. Put differently, what I've heard from some, and I would love for you to speak to if this is what you're hearing or it bears out in your statistics, is that it's harder to get people to commit to a school building 5 days a week when they can telework and provide services or support or work a more flexible schedule. As we're grappling with how do we meet the demand on the ground, one, is that what you're hearing, and or could you provide any other information? And two, what should we be thinking about in addressing the shortage of social workers, namely within our schools, but in other places?
You know, one of the things that comes to mind is that we really need to do a bang-up educational job on the opportunities that are provided by the social work profession. It's a very diverse field of practice. Many people come into the profession wanting to go into private practice, and that's certainly honorable. But we also want to inspire people who are interested in the profession in to work in the public sector, to work in our schools, to work in our other departments where the need is great, where we have a a huge vulnerable population in need, people with mental illness, our homeless population. There is a tremendous need for people to work in the public sector. We recognize that the work is very demanding, and sometimes it may not seem as attractive as working in private practice as a therapist. However, we know that that work is also very rewarding and is certainly very integral to the nature of what social work practice is all about. So I think we need to do a better job of inspiring people to look more broadly at what the profession offers and where the work opportunities are. In addition to that, we need to increase the number of people coming in, and we're looking at a number of ways of doing that. For example, we are investigating the possible benefits of developing compacts with the surrounding states, or also doing reciprocity with these states, so that we broaden the boundaries in which the profession operates and will be able to bring more people into practice. Now, it's very attractive on the surface to do some of those things, but at all times we must remember that we have to be aware of the fact that we have a responsibility to protect the public. And so we have to be concerned about safety. And of course, when you start talking about compacts and reciprocity, we would not want to, we also need to simultaneously we need to be able to ensure the safety and competency of practice for our residents in the District of Columbia. I don't know if that gets, helps to answer the question. I think it does.
So what I'm hearing you say is we need to attract more people to the field. And what I heard in the last part is that we need to hold the bar high so that we have competent social workers. I guess to your point, though, in the public sector, there is a real need we were just in the CFSA hearing last week, and they are saying we need social workers. We talked with our school personnel, and we need social workers. Even on the housing front, to your testimony, we need social workers. And part of the solution that some are providing is, well, if we think about easing up the requirements in some of those, I don't want to say low level, but entry level opportunities for social workers, maybe we'll attract more, maybe those that are not going to see high risk clients or provide certain types of, or engage with certain caseloads, we'll be able to better meet the demand. I am just really grappling with how do we meet the demand that we're seeing in the public sector? So I would love your thought partnership over time on that.
Yeah, well, I think some of what I've just said would certainly help to meet that demand. But I also, I think we have to always look at this through the lens of competent practice and safety of the citizens of the district.
But right? Now I'm going to put on my advocate hat. Sorry to overlap with you. Some would say, though, I'm thinking of a housing advocate.
Yes.
We don't need a licensed social worker to do that X, whatever that thing is. That they would argue there are ways to ease the burden on licensed social workers if we think about tiering almost the licensing, which is short of doing away with the exam, as you made very clear you're against. And we heard from some of the other board chairs that they are thinking about different ways of tiering their licensing opportunities to give different access points to folk. Have you all thought about that? Or is that even something you're willing to entertain?
Oh, yeah, we're certainly willing to think about how we licensing is a living thing, but I think that there are instances in which we are not requiring the person has a license to do certain kinds of social work related work. Sometimes it is the agency that makes that requirement. It is not the requirement that we have made. Yes, we do have requirements related to the 4 tiers of practice that I mentioned to you.
Yes.
But we are not, we have no jurisdiction over decisions that agencies make with regard to the requirements that they have. So that may be one piece of it. That doesn't address the entirety of what you asked, but I did want to make you aware of that.
And then I want to come to the vacancy you talked about. Can you just spell out for those that may be watching, what is the impact of having that vacancy for such a long time?
Well, you know, the immediate and obvious impact is that we do not have then the perspective available to us of the person who comes from that part of the profession. And it is really important for us to be able to represent, to the extent that we can, perspectives that come from each of the areas of practice that we are dealing with. And so it's been really too long. We have, I don't know how the council might help us with that. I don't know if some people have applied, and whether, you know, there's a rather rigorous process that they have to go through with the city council and with the the mayor's office of talents and appointments. I don't know what the outreach effort is. There are a lot of practitioners out there who might welcome an opportunity to do this, but they may not be aware of it. We certainly have advertised this on our website, but maybe everybody doesn't look at the website. I don't know. So I think that we need to do some more work in that area to get that taken care of.
Yes, and I'm sure Councilmember Henderson will follow up, as I will, to try to move that along as much as we can. As I asked the other board chairs, are there other ways that we can support the very important work that you're doing?
Well, certainly what we've just talked about, the outreach to getting, you know, if there's a way to get another person on the board to eliminate that vacancy, that would be a tremendous help. I guess I am very pleased and very impressed that you are so aware of all that we are attempting to do in social work. And I think that if you wanted to attend one of our meetings, or have some of you attend one of our meetings to get an even deeper or broader look at some of the challenges that we are addressing, that might be useful to you as you are making your decisions. Yes.
I will take you up on that offer. And our fearless leader, Chair Henderson, has helped just me build my understanding. But as you may or may not know, I come from the education world. And so a lot of that is why my focus has been on schools and just meeting the need there. In my last few seconds here, I just want to come back to the work that I believe you said you're doing with ASWB, just trying to understand the racial issue with those who are passing the exam. Is there a parameter on time of how long you're going to be conducting those conversations across the country, or they are going to be conducting those conversations across the country?
My understanding is that within a year's time, and they may be looking at this in a segmented way, but they certainly want to be able to begin to address in real time with real data that helps us to gain some insight into why these disparities exist, so that we can come up with the appropriate responses to dealing with them.
Well,
and I want to add this too. There are a lot of issues that are tied to even though we all go through schools that are accredited by the Council on Social Work Education. So that means that we all begin with the same level of standards in terms of what is expected, but there are probably tremendous variations that are tied to people's experiences and the point at which they entered the educational process. And I think there needs to be a lot that we look into with regard to not only the conversations with the applicants, prospective or those who have already come forward, but certainly with our universities, look at our educational programs to see how we can begin to close this gap together. This is not a singularly focused.
And in my last, I'm over time. What I appreciate about that is that you're calling on us to be proactive. So not just saying, let's eliminate the exam because the disparity exists, but how can we get in front of it to address the gap? So, thank you, Ms. Spriggs, for your testimony. I will follow up and take you up on that offer to join an upcoming meeting. Sadly, I do have to jump for a public safety meeting I need to get to. And I see Chair Henderson is here. So I'm going to yield back. Well, I have no time to yield, but thank you for your testimony.
Thank you.
Councilmember Parker, thank you so much for pitching there.
We have an addition.
I have new interns that had to be picked up. The joys of late afternoon hearings. So thank you so much, Councilmember Parker. I know you have a safety meeting in Ward 5 tonight. So thank you. Ms. Spriggs, I was listening to everything. So you guys covered a lot of ground. So I just want to pick up on a couple of things and then I'm gonna let you go because it's late. What's that? You want more? Okay, can you hold on? Can you wait? Okay, let's wait. Now, so I understand that you have a couple of vacancies on the board.
One vacancy.
One vacancy. Okay. And are they in the process of actively recruiting or have they identified someone for that position?
I don't know if anybody's been identified. I know they're actively looking, but.
Okay. I talked to someone earlier today who is a LICSW.
Yeah.
And I said, oh, you seem interested in this work. Do you want to serve on the board? And she was like, I have too much other stuff going on. So I can imagine that some of the challenges that you guys are facing are, all right, okay, baby, are very similar to some of the other ones that the other professions are facing. Have you had any quorum difficulties?
Generally not. Occasionally we might have, but our members are very dedicated and so they do try to make all the meetings. Yes. We do need the vacancy that we're looking for is the LSWA, Licensed Social Work Associate.
Okay.
Bachelor's degree level person.
Okay. So I heard a little bit of the conversation that you had with Councilmember Parker in terms of the examination.
Yeah.
Are you aware that Maryland is having a hearing this month on like a bill to scrap it all together? I'm just curious in terms of how that might impact compact conversations that we're having with our surrounding jurisdictions.
Yes, I'm aware that they are. It does concern me because I know that the state of Illinois has already experimented with that model. They did eliminate their exam, but it has come with some problems. The outcomes have not been what they had hoped they would be. And so I do hope that Maryland is really critically examining that option. They're probably feeling a lot of public pressure to eliminate the exam, and we recognize that they're also trying to address the multitude of problems that seem to be tied to the exam. But I think that simply points to the complexity of the problem, and the elimination seems to be a rather simplistic response from our perspective in DC.
Understood. Similar to, I guess, a conversation I was having with Dr. Jimenez and Dr. McCants, do you all survey your members in terms of the number of, well, obviously you have a census in terms of who's licensed, but do you survey which types of settings that they are practicing in?
I do a survey at the time that they renew their licenses. There is a survey conducted, so we would have that information.
Okay. All right. So we'll follow up with Herla on that and maybe try to get some more information on that, because I feel like that can illuminate some things. Like I'll have my staff and I did sort of I would say, very basic exercise of looking at what are the requirements for various jobs. So what are the requirements that we're asking for caseworkers under DHS? What are we asking for caseworkers at a hospital? But also what are the starting salaries for each? And to sort of talk a little bit about that. I guess I might know the answer to this, but I want to ask, like, to what extent has the Department of Human Services or the Department of Healthcare Finance interacted with the board from a standpoint of getting more people into the profession and some of the licensing challenges that they have been seeing?
We have had interactions with the Department of Human Services, for example, around specific issues, but we have not met with them recently to talk about this particular concern.
Okay. Another thing that was raised earlier in public witness testimony was around who can do supervision of whom. And I'm curious if that has come up amongst the board. I think everyone is, we know that we need to do an update to HORA, the Health Occupational License Regulation. And so I'm just curious what conversations the Board of Social Work has started in that regard.
Yes, we have. We talk about supervision quite a lot on our board because it comes up in various ways. We do have guidance as to who can supervise whom, and that is the guidance that we have used in determining the answer to that question. I recognize that one of the questions, for example, has to do with being able to supervise across professions. If you are a social worker with an MSW, or you have maybe a bachelor's degree, can you not receive supervision from someone from professional counseling or from psychology? Is
or
that the
group
thing
supervision?
you're talking about? Oh, yes. We are in the process currently of talking about group supervision. We recognize that there are merits to group supervision. However, we feel that it has a function somewhat different from that of individual supervision. And so we certainly accept group supervision as part of meeting the licensing requirements. And we have in fact put together a small task force to address some of the questions around group supervision. And we're hoping to provide some clarification as to what our position is on that question by the end of May.
Okay, great. So we'll definitely follow up on that. Do you serve on the interprofessional?
Yes, I do.
Okay.
Interprofessional Collaboration Board?
Yes.
Yes, I do.
Okay, I'm excited to be able to work and collaborate with that group. I'm also very excited for, I think, the symposium that they talked about earlier, that hopefully will include you as well. Ms. Spriggs, I would love to be able to chat with the other members of the Board of Social Work as we sort of try to dig through some of the more meatier issues, because I feel like your profession, perhaps maybe more than others, it digs into schools, it digs into some of the housing, human services issues, it's dealing with the hospitals, it's dealing with caseworks and nursing homes and all of these different types of things. And we need more people, but I want to make sure that we are doing it in a way that elevates quality and not just quantity. But I have some more technical questions that I can definitely get into with DC Health on Thursday for their hearing. And as you can see, my interns are being interny right now. So I want to say thank you so much for your testimony.
Well, thank you for inviting us.
I would say thank you so much for your testimony and for being here today. And then I'm going to wrap up this hearing. So You can turn off your camera or whatnot. I have a couple of other things I need to say, and then we can wrap it up. So this concludes my questioning, and I want to thank everyone for providing testimony and information to the committee. As I said, if we have additional questions, we will likely follow up with, well, first off, we will most certainly follow up with DC Health and HRLA at the hearing on Thursday. For anyone who was not able to attend and speak at today's hearing, we will be accepting public testimony until March 14th, 2023 at 5 p.m. You may submit written statements to Ashley Strange at astrange@dccouncil.gov, or you may leave a voicemail at 202-430-6046. Again, 202-430-6046. If you leave a voicemail, please remember to speak slowly and spell your name for the record. As I said at the top, there are lots of licensing occupational boards or occupation licensing boards within DC Health. We chose 5, but we do plan for this hearing, but we do plan to try to make our way through the others. I've heard, that came up even today. The Board of Dentistry will be coming to see you soon. The Board of Professional Counseling, and some of the others. But this concludes today's hearing. Our next performance oversight hearing for the Committee on Health will be for the Department of Health on Thursday, March 2nd. That will be our last performance oversight hearing for before the budget process begins. The time is 6:12 p.m. This hearing is adjourned. Thank you so much to Office of Cable Television and for all of you for being here today. Thank you.